I'm the next speaker after you.
Yeah.
Oh,
We are like, yes, all our speakers from Maccabi today. You are most welcome.
okay. So now I don't see everybody. Everybody there? Should I start? Do you have a
Yeah.
reset now, or how is it going now?
No, it's okay. We can see you.
Okay. So I'll start with a story.
Yeah.
Year 2017, I was driving from my clinic in Kiryat Gat in the South District of Israel to my other working place, which is in Tel Aviv. And I got a phone call. A phone call saying, Dr. Ilan, are you free to suture some patient? Are you free with this kind of language? Are you free to suture this patient? It was a friend of mine. She's working about 40 kilometers away, and I wasn't free, but that gave me a click, like an idea that why should we do that in this kind of way, that people will call each other and ask if they can help them once we can do it, like Uber. Does that remind you of anything? If someone asks you, are you free in Dizengoff? Are you free in this street or that street? So why should we do it in this way? Let's do it in a way that it's going to be more like Uber way. So that was the idea. That's where it came from. And that's what I'm going to talk about today. So my name is Ilan Yoshua. I'm a family doctor. That's the first thing. I'm a specialist in family practice. I'm the head of the family practice training program in the South District of Maccabi Health Services. I've been doing that for 12 years. Before that, I was studying my degree. I was in the Ben Gurion University in the Negev, and I done all my training in Maccabi Healthcare Services, apart from 5 years. There was 5 years that I was. We traveled to Australia. My wife did pediatric intensive care, and I went to do first to find myself and to do some studying, but then pretty quick I started working as a GP, a family doctor over there. And when you work as a family doctor, I was working as a family doctor on an island, which was outside of a place called Brisbane. So I had to do a lot of things by myself. It suturing, injecting intra-articular, inter-joint injections, and a lot of excisions and surgeries and stuff like that. So when I came back, when I went to Australia, I was already a family doctor specialist and a manager. So I had this kind of thinking, what can I bring from Australia back home? So it took a while. I came back 2013. As I said, in 2017, I had this idea. Once I had the idea, while I was still on my way, I called my other friend, which is in the management in Maccabi, and told her the idea. And she got so excited. Noah knows her as well. Her name is Miri Mizrahi. She's now not in Maccabi anymore. And she was so excited. She said, "Yes, let's go for it." And basically, she assigned a very important and nice lady that's called Limor to me. So I said, I cannot do it by myself. I have too much to do, but I do want to do it. So remember all those sentences that I'm telling you today. So that's the idea. You see, as you can see it here. So it's like Newton when the apple struck his head. I did not know what I'm getting into. So basically, I thought, wow, that's going to be fine. We'll do some sort of WhatsApp, some sort of maybe more advanced kind of WhatsApp that can connect doctors and use them as Uber. So what basically we know about this situation? I have to say that as a manager and as a family doctor and worldwide, everybody are concerned about the amount of ER visits. It's worldwide. It was the same in Australia. And when I go travel, I'm as I said, as a manager and as a academic in family practice, we travel a lot to Europe to research conferences in all places that we're going. They're all concerned by the same thing. They're all doing whatever they can to try to avoid referrals to the ER, because ER referral is never ending in ER. By the way, if anyone has any questions, feel free. It's okay. Maybe I'm forgetting something. Whatever you want to ask, feel free. So ER concern is a big thing, especially in the Western world. places like Netherlands, Belgium, they have like those doctors, like family doctors that work as shifts, long hours to cover for that things. Other places, they like Australia, they give a penalty or a fine to those ERs that need to shut their doors, because that means that if they needed to shut their doors, they did not do good enough job with the GPs, with the family doctors, not to send so many patients to the emergency room. So as I said, it's a worldwide concern, mainly waste of time for patients and overcrowding in the ER. I'm pretty sure most people here are doctors, or some are not. All people here are doctors. Can someone answer?
Some are doctors, some are nurses, some are engineers, biomedical engineers.
Okay.
So different aspects, but all are entrepreneurs.
Okay, very nice. So I have to say that everybody knows that doctors, especially everybody that go to the ER, unfortunately, one stage, that it's overcrowded. Most people are not satisfied with what they get, and it takes a long time to get your treatment. Just have one story of my son. As I said, I'm let's call it a senior doctor. My wife is a very senior doctor in the hospital, and he had this emergency in his testicles that we needed to go to the hospital. And it doesn't matter that we were seniors, we had to wait for about 4 or 5 hours just to see the ultrasound and to do the ultrasound and to know that he need to go to a surgery, something that I knew that he need to go to surgery straight away. Didn't need to wait, but the whole system is very, very long and not very efficient. And it gets a lot of referrals that there are no reason for them to get to the emergency room. So basically, and the second thing is community-based physicians are at high risk of burnout because of their routine and dominated by administrative tasks. So a lot of places in the world send a lot of administrative tasks to the GPs and other community doctors. They want them to do so many things for the patients. It's all coming from good reasons, but it makes the doctor burn out. And they do not have the opportunity to do what we call the medicine of your top of the license, which is a nice phrase that I learned. Top of your license means if you are an orthopedic surgeon, mainly what you want to do is to do the surgery, orthopedic surgery, or treat fractures, or do something that is part of the treatment of your training. You do not want to treat backaches. Orthopedic surgeons, I know that a lot of people in Israel think that orthopedic surgeons are for backaches, but they do not want to treat backaches. They want to treat surgeries. They want to do surgery. Same with ENT. They do not want to take wax or cerumen out of your ears. They want to do what they trained to do. So if you do not do that, a lot of research shows that you get a burnout very quick. So basically, that's another problem, which my invention took care of. So this is the way ER looks. Nobody smiles there, so usually it's even worse than that. So what I came, so Maccabi Red, which is, as I said, started 2017. It was an innovative urgent care search and match system. So especially it's like Uber. We cannot call it Uber because Uber is for driving and maybe but the mechanism is the same. So you take a service that already is available. So we have a lot of clinics in Israel that treat many things. So we have all the specialists, and we have all the family doctors, which a lot of them are specialists, and they're all there. So they really want to take care of and they know how to take care of urgent, semi-urgent conditions. But for some reason, if someone will have a fracture, he will find himself in an emergency room treated by a resident that maybe is 6 months into his residency. He's not really the best practiced physician. The ones are in the community. So I said we need to make the system to make it available for someone that wants to be treated for semi-urgent condition. I'm not talking about the one that is life-threatening, which is not the case, and we needed to build a system to make sure there's no life-threatening conditions in this setting, because it's very tempting to do that. So it was a nationwide network of it was started as 813 doctors, but basically it's now much more than that. based on Maccabi HMO physicians and able and willing to treat specific minor trauma and provide semi-urgent medical care. And when I say willing, maybe I needed to highlight this, we do not make anyone join the service. For them to join the service, they need to want to join the service. And the main thing, they're going to get and see the patients on top of the list. So they say, how come? So basically, we gave a special payment for just for the willing to see the patient. So the one that accept this patient gets a special payment or extra payment, which is not huge, but it means for the patient, for the doctor, that you're not taken for granted. And I'll show you how it works, and you understand that it's not a necessity. Nobody should. It's like with Uber. Nobody has to take the call of the Uber. So basically, I'm sorry it's in Hebrew, but that's how it looks on the app, on the app of the patient. He chooses what we call emergency medicine, and he goes through it, and basically he eventually gets to the point that the system tells him, okay, we're locating a doctor that will accept you. I'll go further. No, that's not what I want to show. As I said, so patient present with a semi-urgent need of immediate medical care during regular operating hours of community clinics. So we're not talking about the over hours or the late hours. We're talking about until 7 o'clock at the evening, which is most patients. That's when that's when they get injured or when they need something special. He goes through a triage. The triage can go either by a nurse or another physician. So let's say I'm a family doctor sitting in Kiryat, and someone comes with a suture that needed a suture, and I don't know how to make sutures. So I can go through my records, push this button. They will start the whole cascade of looking, which is everything is seconds, looking for someone that is willing to do the suturing, and everybody will get the call. So nurses and physicians uses that to locate appropriate nearby physician in the red network. Red networks can confirm the call. The one that confirms the call, basically all the rest are getting, that's it. That's the one that's getting the call. So we will have this thing that you'll see straight away. Now, the other way to do it is either patient can start with the app, and as I showed you before, they can start with few very quick steps, just asking them what is the condition, because again, we do not want anything very urgent or the wrong situation traveling around places when they have like a life-threatening condition. We would not put there some older patient with chest pain to start looking for a doctor. That's not the case. So basically, patient can do that. They have this triage, digital clinical triage. I'm the one that built it. So basically, we've done it very narrowly. So we did not put any condition that maybe we don't really know what's going on and stuff like that. And then they operate the same system as if you would operate the one from the nurses and from the doctors. So what are we talking about? So again, do we have like this slogans? You'll see where it took us to. So we're talking about a convenient treatment nearby. It's a near ER alternative in the semi-urgent medical care. We're talking about foreign bodies like in ear, skin, eye, urgent, but not life-threatening OB/GYN conditions like bleeding during pregnancy, a little bit of bleeding, or maybe things like a little bit reduced fetus sounds and stuff like that. Injuries are major thing that I'll show you soon. Sprains, fractures, like regular fractures. I'm not talking about anything that is dramatic. Dislocations in minor surgery is sutures, abscesses, drainage, burns, etc. The etc. on the left side, that's for a lot of conditions. Sometimes you cannot define exactly what's wrong, or let's say some patient comes to the nurse are not happy with him. She cannot say exactly why, but she wants a doctor to see him straight away. Let's say that he's been dehydrating, just a case that I had just before I came here, baby, 18-month-old baby that was vomiting the whole day 6 times. He didn't look really bad, but he was vomiting a lot, and the nurse said, if I'm not gonna put him to see a doctor, or some doctor will accept him, then I'll have to send him to the ER. So she said, I don't want to send him to the ER, so I start the Maccabi Red, and then she found me, and then I saw the baby, I look after him, and then we saved the ER expenses, and the family was extremely happy. So this is the etc. The etc. on the left side means a lot of kind of etc. So it could be from shortness of breath to someone in even places when someone is very, very anxious or have like this panic attack and are very, very stressed and nobody knows what to do with them. All those without the Maccabi Red, I can assure you, and I checked it, will end up in the ER. Okay? Do you have any questions by now? Do you understand the mechanism? Okay, so we look, so how it looks. There's this, let's say this doctor on the right-hand side where I show you. Do you see the cursor over there? And he's looking for, he found a condition, and someone has a foreign body somewhere, and let's say in the eye, and he cannot do or doesn't have what needs to take the foreign body from the eye. So he sends a Maccabi Red request, and instantly this thing on the left-hand side pops to many doctors that can treat it. If it's, and we determine which kind of doctors can treat any kind of condition. In this case, because it's a foreign body in the eye, it'll be ophthalmologist, mainly, or just ophthalmologist. So one ophthalmologist sees it and he works at that time and he says either accept or decline. So in this case, he accepted, he will get the patient. Again, let's see it through the app. So this one was through the doctor, now through the app. Same thing is the emergency medicine over here, this button on the right-hand side. He presses this button, the patient, then it's asking him few questions. Where is this foreign body? Is it in the eye, in the nose, ear, skin, or mouth? And then when did it happen? And so on and so forth. If this algorithm will think that it's not suitable for this kind of service, then it will transfer them straight to the back office of Maccabi, and they will find the solution either by sending him to the ER or to find him a doctor in another way. So they're not going to throw him away. There's no case that someone will say, oh, okay, we don't know what to do with you, just go back to. Once he started it, you're going to get some sort of solution, which is a good thing again, because it means we found a way to fix something that another thing that was a problem, that all those urgent patients that nobody knows what to do with them, or they can fall between the line or fall between the. So again, this message pops up on my screen when I work in my clinic, and it happens about 6 or 7 times a day. I don't have to take the call because I'm too busy or I'm finishing my work and I don't want to take the call. So I can say decline, or I can do the accept. Now, it started in my area in Kiryat Gat because that's where I work. So we are the first place to do the trial of this system. And when we started, it was a lot of hassle and a lot of things. And you know, when you change things to doctors, they always look like, and they have all these reasons to tell you why it's not going to work. But nowadays, I can tell you that once you get this call, maybe 2 or 3 seconds it disappears. So everybody are looking for those conditions, the Maccabi, as you can see over here. So and the one main complaint for a lot of doctors is it's disappearing too quick. And we say, what can we do? It's kind of a free world or a free economy, and whoever takes the call takes the call. This one said this guy has a foreign body and please accept him. So you do know in one sentence what the patient has. You don't have to accept. If you feel that you're uncertain about treating this kind of condition, you don't have to accept. So we are looking at it all the time. We're doing research. We already published already more than 2 articles already, and there's more on the way, because now it's been already 2017 that we started, but in the nationwide, I'll show you soon when we started. So basically, this is a little bit old data, 73% of all the calls that we're getting, because you know some kids sometimes play with it and stuff like that, is an appropriate physician was available in the patient vicinity. So the system found an either ER or just a physician that is ready to accept them. So 73% were appropriate, which is a very high percent. 85% of those qualified as ER suitable. What do we mean? We checked them, went one file after the other, or we sampled them, and we saw that there were really things that if you do not, or conditions that if you were not going to treat them with the doctors that we send them to, they would end up in the ER. So that's big savings for the organization. Now, that is, if you ask me, that is the thing that I'm so proud about, which is and the most proud about. Patients were seen by the physician within 1.1 hour on an average from referral, as opposed to at least 4 or maybe 5 hours in the periphery of Israel if they go to the emergency room. That is huge difference. So it costs much less, and then it's in 1.1 hour from call to end of treatment. That is amazing. That is definitely amazing, and that's on average. There's some people that are much faster than that. If you look only at the beginning of the process, so let's see here on December 17. So I didn't tell you. June 17 was the story that I told you the beginning of the story of the condition. December 17. June is when I started, when I said the idea. December 17 is we started already the pilot. We started already the beginning of this process, and we started with 23 cases, which was amazing for me. One of the first cases was a kid that was about 7 years old with a fracture that was obvious because I saw the kid. I've sent him to do an X-ray. The fracture didn't look good at all. Wasn't this a normal fracture that I can treat myself? So I said to them, look, I can give you 2 options. I'm doing a Maccabi Red. If I'll find someone, you might need to travel maybe even 30 to 40 minutes, or I'm sending you to the ER. And I did find a doctor within 40 minutes. So the doctor, I got this, we're getting this approval to say that I got a doctor, orthopedic surgeon. 40-minute drive to Netivot, which is about 40-minute drives, and he went there, and he not only put the cast, he said, if you went to the hospital, most probably they would do a surgery in this condition. So as you know, there is many conditions that you can decide either to have a surgery if you want to go to the safe side, or you can do a reduction in orthopedics and maybe put the cast. And he did that. And it took him a long time. It was the first case, and I was so proud because for a few reasons. One reason, orthopedic surgeons in Israel are maybe one of the most burnt out doctors. So I didn't even believe they want to join the service. Then not only joined the service, he got them on top of his list that was very full, and he done an excellent job. So the patient came back to show me the cast and to say, look how great job he did. And I was so proud. I didn't believe that was going to happen. I didn't believe that as someone that was on top of this whole process. I didn't believe that ophthalmologists that envily did not allow for any extra patient to get into the list would accept all those patients. So that's pretty amazing. It took a while, and you see we started gaining more patients in each every month, and we went to July 18, and then we went on and on and on. On about this area, it went to be a nationwide process, and we started spreading the word all over for patients and everything, and you can see the start of the jump. Between that, when I was talking about this process, I was skeptical of myself, but I did not let go at any minute. So I had the CEO of Maccabi, a very serious man, serious guy that you do not mess around with, coming to my clinic. He came to my clinic because all the other people that was really enthusiastic about the process, that you are the only one that can convince him and to be enthusiastic enough to make him go through with this process, and especially, as you can imagine, everything you have to put some money into it to start with. So he came to my clinic, and when it was very busy, then we had a talk. He was very skeptical. He can deliver the sense that what you're saying is not acceptable for him. He was skeptical. He looked at us. He listened to my whole lecture, all my convincing. And of course, the first thing he told me, but how many people are crazy like you to do those things? So I said, there's more. And he said, well, maybe 2 more. Then he thought a little bit and said, okay. And the second thing he said, if you get to do 1,000 cases of that in a month, I think he talked of a year, that's it. That means this process is in. I remember those words because that's what happened pretty quick, as you can see, from getting into the nationwide system. Now here I am until August 2020, and I'm now going to move to here and see what happens. That's when we started. That's a yearly rate. Then we went to 28,000, then to 46,000, and you can see now, when we're still not getting into the steady state, 120,000 cases of things that was supposed to get, or at least 75% of them were supposed to go to the ER and did not go to the ER and got their treatment in the community. What now? Which is, if you ask me, very, very amazing. We got to the point, to the opposite of what I was telling you before. If I had to convince doctors to get into the service, now I had a talk a week ago of doctors complaining how come they are not allowed to get into the service. So they're not really not allowed. They just need to go through some training, very short training in some things, and then they can get into the service. But they were complaining how come, and some of the things they can treat, and only some sort of doctors get that, and not other sort of doctors. So we went to one end to the other, and another end, which is a negative thing on influence. Some doctors starting doing abuse for this thing, which means they convince the patients to use the service so they can get a little higher payment. So we done this regulatory kind of thing, and we put some thresholds where doctors cannot do that. And basically, and with all that, we still have 120,000 cases. One of the things that was really, really fun for me or fun, or a lot of proud for me, is to hear ER doctors saying that it's really noticed that, at least in the South as of that 120,000, I would say South is at least 30%, maybe even 40%, because it started in the South. And another thing, as you know, or maybe you don't know, we have only 3 hospitals south of Ashdod, which is including Ashdod. We have Ashdod, we have Barzilai, and we have Soroka. And basically, that is a huge area. And where I work in Kiryat Gat, if I need to send someone to the ER, it's a 40-minute drive, no matter which way you go. It could be 40 minutes to Soroka, 40 to Barzilai, 40 to Ashdod. So if you have a service, the family will be so grateful if you can treat whatever you can treat. And basically nowadays, my biggest problem is to tell them, look, I cannot do it now, go away, I have to send you, because they're getting anxious. Why you do it so well? Why don't you do it in your place? So basically, the numbers are going up. And as I said, about 30 to 40% is the at least in the South, or in the North, I would say at least 20% more. So basically, it is not only doing what is need to be done, but doing it in the right way, in the right places, because the periphery is where you want to have this kind of service. So they have them in the center as well, but the use is in the periphery, as you can see, is high. What cases do we treat? So now, according to case by the medical specialty, so according to what the cases were. So where is it? 70% are the surgery stuff, which is mainly done by family doctors and a little bit by pediatrics and surgeons. The very tiny amount is surgeons. 70% is all those abscesses, sutures, all sorts of abscess sutures, sometimes ingrown toenail, or some sort of pain that is really, really, you know, like a severe back pain or severe abdominal pain that nobody, that need to be treated right away and stuff like that. 70% are OB/GYN, again, and that's after reducing all the things that are really urgent. Still 17% have been seen by OB/GYN. As you can expect, 24% are by orthopedics, which is all the fractures, the sprains, strains, and dislocations. Again, 24% cases that you can be assured that things that if you not treat them in the community will get to the hospital. 40% is the ENT and ophthalmology, mainly foreign bodies, and maybe a severe red eye and stuff like that. And 28%, as I said before, is the other, which leaves a lot of judgment to the nurses and to the doctor, to the other doctors, to say, look, I'm not happy with this patient. I want someone to see him or give him fluids, and I cannot give him fluids, or give him this and that medication, whatever that I cannot do here, and they send them away, and which is very, very, I'm very proud about as well, because we did not just say, oh, you cannot send them only if you have all those conditions. We gave them this thing that they can think what they want and use it whenever they want it. So what the conclusion, the benefits is real-time community-based solution to those semi-urgent medical needs. I have to say, we looked all over when we've done all our research. There's nothing even close to it anywhere in the world. As I said, I worked in Australia. I know exactly how the same thing goes for New Zealand. I have doctors working in New Zealand, like extra residents in New Zealand, in Canada, in the US, in many European countries, nothing even close to this kind of treatment. Part of it is because it is based on a very good computer system that you have in Maccabi, and you can trust it that you can do all this thing, and the computer will work as you want. It's one big network that's all connected, and basically it's no, I think it's no problem, because I'm not an IT man, but I did sit a lot of time with the IT man, and they all said, yeah, we can do this and that. Like this thing of the pop-up, I remember, it's a funny story, that I was in this meeting with all these IT people from all sorts of sectors of Maccabi, and then I said what I wanted to do. I wanted this pop-up that will pop up on top of our EMR, of our medical records. And they looked at me as if I'm asking for, I don't know, to bring the moon down with a rope. And I said, look, I don't know what it means. I just know that's what I want to happen. And they started, all the heads went down. They looked very, very stressed. How can we do that? I forgot to say, once the CEO went out of my room, he basically, it looks to me like he thought about it again. He said, I'm going to give this budget so you can do it. And the one thing how do I say? He was really hooked about is that it's going to be this app, and he wanted the app to be in Maccabi, and it need to be developed in Maccabi, like in-house as we call it, and it need to be fast. So everything that IT people hate, and that it need to be fast, that is a top priority and stuff like that. That was pretty amazing. And basically we sat because they wanted to hear how can we do and what exactly are the needs, so they can do what they want, to do the work. So when I asked them to do the pop-up, they looked at me and they turned the heads down, and then someone said something in IT language which I do not explain. Hey, I have an idea, let's do it this and that. And then everybody started smiling. Oh yeah, that's a good idea. And then I understood that it can happen, because I was sure there's no way you can do this, what I was asking for. And as you can see, it's happening every day, all the time. So we're getting basically an optimal and utilization of the community-based physician clinics. As you can imagine, there is, as I said, it costs money, but as basically it's supposed to reduce the amount of the cost of ER, because someone that is sent to the ER, it's a fixed price of about $1,200 shekels that you pay to the hospital, or the organization pay to the hospital. The most expensive of those referrals would cost maybe 500, the most expensive. Most of them would not cost more than 200 or 300. So that's a big save. And if you go to those 120,000, or at least 90,000 out of them that were supposed to go to the emergency, you can calculate how much money it is. Of course, nobody comes and say, "Oh, yeah, thank you very much," but they start saying, "Oh, it costs so much. How come it costs so much?" and so on and so forth. But that's the way it goes in Israel. The patients are getting better, immediate treatment with less hassle, as you saw. As I said, 1 hour, 1 hour and something to get a treatment that's excellent for someone that has a condition that he wants to be solved. And the doctors, we checked all that with research. It's higher satisfaction, both with the doctors that referring and the doctors that are getting the situation. So rarely you get situations that doctors are happy about something, but they're happy. The satisfaction is high. Saying, instead of sending someone, I don't know how to open an abscess, but instead of someone with tiny abscess, or to send someone with something sticking to his ear or in his eye to the hospital, I operate this thing, and within a few seconds I have a doctor taking the call. The patient is so happy and unbelieving. The 120,000 that I was telling you about is when we started advertising and we stopped advertising, and I'll show you all sorts of things that related to the advertisement. So basically, a lot of the patients still doesn't know about the service. One thing that is really important to remember, that the Maccabi is about 2.5 million patients, is responsible for 2.5 million patients. So basically, if they decided to make more, to advertise it a little bit more, that might increase the numbers by far, because as I said, still a lot of patients don't know about the situation, about the service. And as I said, satisfaction. As I said, you see in the red down there, less ER visits. And this is one thing that is very hard with the research to determine, because you cannot compare one time to other times. So basically, you cannot compare the time of Corona to the time without Corona with ER visits. So it's hard to decide how exactly we reduce the number of ER visits. But as I said, once we checked the Maccabi situation, we saw that basically we reduced the number dramatically of the and a lot of the cases were ER instead of ER referral. So as what we like in any kind of process that we do, if we can do a win-win-win situation to all sides, and we have a win here for the organization, we have a win here for the patient. No, I go back. The first win is for the patients, because that is the most important thing. Then we have a win for the doctors, and it's very important, and then a win for the organization. There are not many processes that you can be proud about doing all those three wins. Now, of course, there's an extra benefit for this thing. So I took this process, as I said, to some places. I already showed it in conferences overseas. And we took it to the biggest competition, or technical medical health and technology competition that goes yearly, and the price is about 150,000 shekels, and we won first place. As you can see me here with my associate. On my left is Limor. She's my dear associate, and thanks to her, without her nothing would happen. Alon is in the far left side, the tall guy, and he was helping us doing a lot of the drilling down to see exactly how the cases are managed. He's a ER doctor and a family doctor, so you can see from both sides. And this guy in the middle is from the board of the tournament, from the competition. And it's very nice to get this award. It went to I didn't take it to myself, but I can use it for research and stuff like that. Another thing, as fun as it sounds, as I said, we had about 2019 and 20. a series of ads, like TV ads and then YouTube. So one of them is on the right side, and it had this nice tune. And the patients of mine were so surprised and so appreciative, saying this is tune and they like it so much, and they did not believe it. A kid said, "Hey, did you invent it?" I did not invent the song, only the process. I was so happy with the song and the whole thing that they go through it. And this Dir Miller is one of the most famous comedians in Israel. He done this promoting of oh yeah. Okay, so I done all that promotion, and in even this ad won a first place in the ad tournaments, and he got the first place there. So even that won. So from there, let's talk just a few minutes, and then if you have questions about how to generate a change. So basically, I did not really need to be on the top. It's what we call KISS. As one of the presidents of the US said, keep it simple, stupid. It need to be something that you can explain in an elevator pitch. And if you can explain it to your grandmother, then it means you have a good process. And I can explain it to my grandma. She's not alive, unfortunately, but to my mother. And whoever I explain it to him, a simple person or a very smart person, get it within 1 minute. They know what you're talking about. So it needs to be a good idea. And say, okay, what is a good idea? That's a big question. It needs to be a good idea, because if it's not a good idea, nobody will look at it. You need to create a solution to a real problem. So sometimes people have an excellent idea, but there is no problem to solve with that. Or the problem is very, very is a minute problem, or not very not concern a lot of people. So basically, when I say to a real problem, a lot of things drill down to money, but not only. So a lot of good things that happen, and there's no money involved. We have to bring partners on board. And when I say partners, as you see, when I had the idea, the first thing I did, I called my friend, my good friend, as she was in high places in Maccabi, and said, are you with me with that? And she brought me in, and she brought another partner. And we brought so many partners, ending up with partners from all over Maccabi to help us, because we cannot do something like that by ourselves. We need the CEO, we need all the help we can get from IT people and from forgot the word of it, IT people, and from the medical people, and from all over the places, and for people in the headquarters of Maccabi, and from the people in the field of Maccabi. And we need everybody. So basically, if we do not have partners, the chances of succeeding are not very high. We need hard work. Nothing happens without hard work. There's no magic. It's not an Hollywood movie that you jump from one for 1 second, and then you jump to the end, and you see how they all live happily ever after. You need to work hard. I did not plan to work that hard, but what could I do? Because I moved to the next one, which is engagement. If you're not engaged, don't expect anyone to be engaged. So basically, a lot of times, because I'm now looked at as someone that is innovative, that someone that people turn to say, hey, Ilan, let's do this, let's do that. And I say, I will show you the way to do it. I will open maybe the doors, but you have to do it yourself. I'm not going to be the one doing it for you. And that's what people want. They want to have an idea, and someone else will do it for them, or most of the work. So you have to be engaged yourself. I don't know a way to do it without you being engaged. Perseverance, very, very, very important, because basically there's so many obstacles along the way. I remember people turning into me and taking me aside and saying, Ilan, it will never work. So trust me, you're putting too much effort, it's not going to work. And people putting obstacles, saying, why this and why that, and why do you want to pay for money for this, and why do you want that? And even for now, when I went to this talk a week ago, people are not coming from saying, look, it's an excellent thing let's perfect it. But they're going like, oh, how come it's this and that? But eventually we got to the place where we were talking the same language, but it did not start in this way. And everything in life, you need a little bit of luck. You can come to someone and in the same minute is I don't know, in bad mood, or I don't know, he woke up on his left side, or I don't know what, and he said, go away, I don't want to hear about it, it's not going to work, and that's it, and you're going away. Any of you knows, any of you know how many times Herman Melville sent his book, Moby Dick, to the how do you call them, editors, to places to take it out for him, to publish it for him? Do you know how many times? He sent it 100 times for places, and they all rejected it until now it becomes one of the biggest novels. So yeah, we need a little bit of luck. So that's my 2 cents. That's my experience. And as I said, I'm happy to share it with you, and I'm happy to hear some questions. So
Thank you, Dr. Thank you very much.
Yes, I have a question.
Yes, Rami.
Okay. About business plan, I want to
Yeah.
ask, what the difference between Maccabi Red and the other emergency medical center from the business?
Present yourself? Can you say a few words about yourself when you ask Ramez? Go ahead.
Hello, my name is Ramez Kadura. I'm from Akko. I work in Sheba Medical Health.
Yeah.
Okay.
So if I understand your question, I'm looking in HMO, in Maccabi Healthcare Services. As you know, most patients are seen in the HMOs in Maccabi, Clalit, Leumit, and Meuchedet. From all visits, of all patients of all kinds, about 98% of them been seen by the HMOs. Only 2% maybe goes to the hospital. But still, as you can see, and all the experts are well, almost all the experts are working in one of those HMOs, in one of those 4. But it ended up as this weird way that all of them, when they have the semi-urgent condition, they go to the ER. The ER cannot really treat them all, and there is no reason for them to treat them all. There's all those patients can come and get the service in a clinic in Akko, in a clinic in Kiryat, in a clinic next to their home. They don't go to the emergency room. That's a huge difference.
But I think in the emergency medical center, this is the purpose for them, because we have in Clalit the same as we have CT, MRI, everything you need. You don't have to go to any emergency medical. You don't have to go to Nahariya or anything. You just go to Ishpuz if you have an emergency or critical thing that you have really. So you pass the emergency room. They give you tchayvut, they give you hafnaya, so you can pass the emergencies. You go to the department or something.
I'm not talking about the conditions that are urgent. I'm not talking about like someone that has, I don't know, a heart attack or have like a stroke. I'm talking about the patient. He had a small cut on his finger, and he needs someone to suture it. That's all he needs. Okay. Now, before I went through hundreds of thousands of referrals to emergency room, and I saw that they got to the emergency room. Is there a reason for him to go to the emergency room when there's a doctor 2 meters from him that can suture him and send him back home? No. Is there a reason for someone that has some small object in his eye to go to the emergency room? No. He will see the resident. He's not going to see the specialist. The specialist is sitting in the Kupat Cholim. So you're going to see. So this system make him go to doesn't make him help him to go to see the doctor in Maccabi, not to go to the emergency room. And in 2 seconds, he'll take it out and send them home. And they're all happy.
Thank you.
Okay.
Amjad? Yes, Amjad.
Okay. Thank you, Doctor. So my name is Amjad Shurafa. I am working on disease registry for Ministry of Health for Abu Dhabi, and also leading and managing 2 clinics in Maccabi. So I
managing 2 clinics in Maccabi.
Yeah, in
And I'm teaching you how to be an entrepreneur. You're greater than me. So,
So, Doctor, I have a couple of questions actually. I know that there is a financial impact on what you have developed.
Yeah.
But I need to compare this versus what we can develop soon. So, how you handle the limitation for the old patient? Like, not each one of the patient can use the new technology. Open the app, put what he's looking for, like for himself, he has like a foreign body or has like a cut wound. And how you handle even the language limitation. So not all will use the app. Like I selected the doctor, he's speaking Hebrew, but I speak Arabic. And also you have mentioned that this is a real time. So are you using like a geomap to know which patient, which doctor is closer to this patient, or how you handle all
That's a
this
very
stuff?
good question, Amjad. So the good thing to do, if you can use whatever available, something that is already available in Maccabi, and as little as much develop new things. So we did develop this section of the app, but the whole system is sitting on a system that is already available. Let's say you're calling Maccabi somewhere and say, I need an eye doctor in Afula. What he'll do, he will immediately know that you are from Afula, and he will look for doctors around you. Now, if you'll tell him, no, I'm now living in Tel Aviv, he say, okay, no problem, I will do that in Tel Aviv. So we already use this system that know who you are, where you're staying, or where you're calling from, on a Maccabi rate. So he knows, okay, now Amjad is near Tel Aviv, okay, so I'll find him a doctor near Tel Aviv. But you might tell them, no, I'm not. You can change it to say, no, I'm not near Tel Aviv. I'm staying near Tel Aviv, but I want it in Haifa. So he'll do that as well. So we use the system that is already there. About the language, so we all the time develop. We're not on a steady state. So I'm not 100% sure we have it in Arabic, but I can check. The language, as I said, a lot of them can use either the app, or if they cannot use the app, they can call the center, as they usually call, and say, look, I need this and that condition in any language that they talk, because they use all the languages there. I need someone to look at my cut, and she will start the same process. So you will all go to the same process as well. Okay. So and eventually.
And what about for the old patient? Are you using like voice recognition for this, or how you are handling the old patient that can't use the technology?
So with all patients, maybe no one knows more than me, but basically with all patients, there is all sorts of solution that has nothing to do with Maccabi Red, but we're using them. Okay, so everything that they need. But I can tell you, as my dad is not alive anymore, and my father-in-law died when he was 101, they knew enough to use to call and just ask for a service, which is something that's been done for many years. So they keep doing the same thing as they did before. They do not know that someone had operated the Maccabi Red and found a doctor for them.
Yes.
So as I said, we used already a system that is already there, and we like the old system, and we use them with a new service. So it was easier. If we needed to invent the whole thing from the beginning, that would never happen.
Okay, thank you, Doctor.
Thank you, Doctor. Dr. Samer.
Yes, thank you. My name is Abu Khalaf Samer. I'm internist, and I work like the manager doctor in Leumit for East Jerusalem. I have several questions, starting with, is this app open just to Maccabi doctors, or it is open to all doctors that he can register in such an app? This is one question.
Yeah.
The second question, is this just for, as I understood, it is just for the Maccabi Southern District, or it is open for every Maccabi, all Maccabi in all Israel?
But more questions?
Yeah. Is this app is integrated in the Maccabi application, or it is separate app? Separate app?
Okay. So let's say, so I'll start getting. I'm old. So it's only Maccabi, because all the Kupot Cholim, they have. I'm a good friend of Shlomo Winker, so I guess you know him.
Sure.
So we're very good friends.
He's my boss.
Yeah, so we go together to those conferences. He was the one that gave me the award from this. So he would love to have the same thing, but to have the same thing, you have to have the same kind of database and to have the same system. They can do the same. I think if they think about it, they can do the same. So it's only Maccabi because I work in Maccabi. And Berlovich, one of the guys that gave me the award, said, your next mission is to do it nationwide, okay, for the whole Kupot. In Maccabi, it's for all districts. We started in the south because I worked there, but now it's all districts, 120,000 cases in all districts. What was the third one? Was another question.
Is it integrated with the Maccabi
Integrated with
application?
Maccabi application. Yes.
It's not. It's integrated. It's in the app. We just added a button that you can press, and it's called the
And
emergency.
the application.
Yeah, and then you can go through. And now they're developing a new one. So basically, but it's everything's supposed to be, as I said, it's not the beginning of the lecture. Keep it simple. KISS. Keep it simple. The simplest you can keep it. If you're going to do it complicated, it's not going to work.
Sure.
Yeah.
As Maccabi adopted this app,
Yeah.
it is like, did they left you any margin of profit? I mean,
No.
it's your idea, by the way.
No, I only had the 150,000 shekels. Yeah, I know I'm a friar. I have this dream. If I'm sure that if I had time, maybe I'll do it. I don't know. If I'll go to Australia, they definitely need something like that because I know exactly their problem. Same with Canada. I have a friend there now, and she said, "Look, they don't do one-tenth of what we do in Israel, England, places like that. All I have to do is to take it and to, expand it." Yeah. So and you cannot register it as a patent because it's not a patent. It's a procedure within the system. So yeah. So I'm a little bit of a friar, but basically no, I did not get any. Only the shouts and the 150,000 shekels, which I do not take to myself. I use as for research and stuff like that.
So
So
actually,
guys-
we can call it portable term.
Not exactly. Yeah, not exactly. It's Uber. it's
Uber,
Uber
yeah.
for
More than Uber.
yeah.
More than
again,
Uber, yes.
practice, portable term is a good idea, but that's a different kind of condition. Because term can do a lot of blood work.
Yes.
I wanted to do that, but it stopped. So I wanted to add point of care blood work. So and integrated point of care blood work, like full blood count. I'm not talking of just hemoglobin, full blood count, and we got stopped. I wanted to integrate pain treatment for that as well. So and we're going to look at that again. I'm trying to boost it again. Point of care ultrasound. I wanted to integrate, but it got a life of its own. I think it's a right thing to do to combine them because not all doctors doing point of care ultrasound, and a lot of patients need the point of care ultrasound, and a lot of conditions you can solve if you have a point of care ultrasound. Even to appendicitis, or think if you have appendicitis, definitely if you think if there's an abscess, a fracture, and so on. So there's still a lot of work to do. As then I said, I'm one person, and moving all those huge, let's call it aircraft carrier. It's a huge, Maccabi is a huge thing. It's not easy. It's a lot of energy. You see a lot of white hair over here. That's from that.
Okay, thank you very much.
You're welcome.
We have 1 minute only. Rula, your question in 1 minute, please, before the next session.
Dr. Musallam, can I speak?
My turn.
Rula, then Dr. Musallam, yeah. In 1 minute. Yeah.
Okay, Rula.
My turn. Okay. Hello, doctor.
Go ahead.
My name is Rula, and I'm a pharmacist at Maccabi Farm in Modi'in.
Yeah.
So
Rula, I got
you're
stuck.
very interesting. I can't hear you. Okay.
Connected.
Does everybody hear Rula? Because she's getting stuck when. Rula?
Rula, I can't hear you.
Your connection is not so good because I can see the rest of them.
Okay, Dr. Ismail.
Okay. My
sorry.
question is, okay, you mentioned that many thousands of patients were treated in the community instead of going to the ER.
Yeah.
Do we know if those patients had the same or maybe even better long-term health outcomes compared to those who went to the hospital, for example?
Very, very good question, Rula. Really excellent question. So that's a case for the research. So now I'm at the stage of doing the research and now we're researching exactly those kind of questions only about the app. So we wanted to separate the patients going through the app and patients going through the nurses and the doctors. By the first look of it, it looks even better. So there's less admission to the hospital, less recurrences. Very few patients after doing the ER need to go to after doing the Maccabi Red will need to go to the ER. But it's a good question that need to be asked in a research way. Do you do research, Rula?
Yes.
Yes.
Do you want to do research? That's a very good question. You need to ask the question in a smart way, because Maccabi likes to, you can take a lot of data, but you need to analyze it smartly. It's not easy. I do a lot of research. It's not easy to find everything that you want, and a lot of time to clean but basically, you're right. The main question that I want to ask is the main question. Really, the most important is about the cost. I really would like to find a way to say, is it cheaper or not? That's it. I'm not going to stop it anyway, but is it cheaper or not? And that's not easy to determine. Even we went to the biggest money people of health money people, and they said, oh, no, forget it. It's too complicated. But I'm sure there's a good way to do it.
Thank you.
You're welcome.
Dr. Ismail, we have 1 minute. Yeah.
I'm Dr. Ismail Musallam. I'm a veterinary surgeon and ophthalmologist. I'm very interested in your application, and there is a good space for applying this to ophthalmology, especially trauma. And you can indeed use the phone camera in order to send it in advance, in order to give advices or directions where to come to you or to go to somewhere else. And additionally, I'm working on treatment for retinal stroke. And this means that time is very important. Then if you can use this application in order to guide patients immediately to a certain place to be treated properly, this will be of a great value to patients. Even if you do not treat them directly, you can guide them to the right place in the right hospital in order to get the right treatment, because might be not available in any and not in all hospitals. But really, your application is wonderful, and don't surprise if you find something in ophthalmology applications similar to that.
Yeah. So
thank you very much.
You're welcome. It's a good idea, and I said there's so many good ideas, but it need to be, I need, like in ophthalmology, I need someone that understand and to make sure, because the main question they'll ask me, isn't that too dangerous to do that through your app? Maybe we will harm someone that was supposed to see a doctor and he did not because he trusted the app. You know what I mean? Or trusted the system. So they ask me that all the time about. I do have questions, but answers to that, but I cannot. I need someone. As I said, there's a lot of obstacles. I need someone to help me because I'm a GP. I'm a family doctor, so I can't.
But it's a great idea. Really, is a great idea. Thank you.
Thank you very much.
Dr. Ilan, thank you very much. I believe we need another session, by the way. Thank you very much. Appreciate it. Thank you.
Thank you. And
thank you very much. Thank you.
Good luck with everything. Bye.
Yes. Thank you.
Doctor. Thank you very much.
Thank you, Ilan.
Hi, now. Sorry for being late. Sorry.
No worries. It's okay. Let me share my screen. Second. Let me know if you can see it.
Yes.
Great. Okay, so everyone, I can't see you now because I don't have you on my screen. So if you want to say something, speak out loud, and I'll stop. I'm very happy to be here. My name is Noa Kerem Dotan. I'm going to talk about product management. I'll explain what it is, and I'll demonstrate how we do it in Maccabi. By the way, the RED project, Ilan's application, which is absolutely amazing, is a great successful. It was created before the product management group was established. So my profession is a product manager. I don't know if you're familiar with this. And my background is I have a first degree in computer science and biology and an MBA. And actually, my experience includes product management in all these different areas that you can see here on the screen. I started in Teva Pharmaceuticals in the pharmaceutical area. I've been there for 15 years, where I did product management for different kind of products in the clinical trials area, in clinical operations, supply chain, and others. And in the last 7 years, I'm part of Maccabi, where I do the product management for the EMR, for the clinical records, and other applications, which I will talk about today. And the product management team in the medical informatics at Maccabi was actually established by me 4 years ago, and I'll tell you more about it. So what's a product? A product is a solution designed to meet a need of users or customers. It's a solution that solves a problem. That's how we define a product. It can be tangible, physical, like a medical device. It can be an application, some digital application. It can be even a service. Service given can be a product. So it depends how we define it. It's very flexible, I would say. And I'll try to describe the role of a product manager in the language of clinicians. So just to make it more understandable. So the product manager examines the users, examines his patient, okay, identifying the pain points for the users, what problem that they need to solve. We review users' behavior, history, we look at the environment, we assess the risks, and then we put together a diagnosis. We diagnose the problem, and starting a treatment plan, we put together a product that is aimed to solve the pain points. That's the treatment plan. We also then document everything, same as the doctor document things in the medical record, and we keep the follow-up until improvement. So that's just in a one long sentence, what is a product manager? But speaking of the business itself, the area of product management consists of 3 pillars. The first is the business, and someone here mentioned the business plan. The product manager must know the business he's working at. It can work, as you can see from my different experience, in different kind of businesses, different kind of area of content, but still needs to know the business, to understand the strategy, to understand the finance of the business, the processes, how things are measured in this business. The second pillar is user experience. A lot of time it's called UX in short, but to understand user experience, what we need to do is to understand people, to understand what they want, what's easy for them, what's tough for them, what they're used to, how can we change their habits if we want. We need to be able to do the research, to analyze the user needs. This is the second competence. And the third is the technology. We must know technology. We need to understand the technology. We need to be able to assess what's feasible to do, what's not feasible to do, what's more complex, what's more easy, what would be a quick win. A lot of product manager coming from the programming background, like me. I took the computer science to start with, and I was programming, and then I developed into the product management, but it's not necessary. And you must know the development process. So if you want to control the process and create the product in a good way, you need to know that. And between all the 3 pillars, this is where the product management sits. Needing to be familiar with all these areas, the product manager is actually the interpreter. He sits in between the business, the UX and design people, and the technology, and he connects all the dots together to work into a successful product. I'll mention that, of course, more skills are required from a product management. For example, she should have a strategic thinking and a good interpersonal skills, because as you can see, it has to work between different kind of peoples and make things work. Leadership skills, and also be a very, very good project manager. I don't know if some of you know this slide already, but what we show on this slide is what happens when there's no project manager or product manager to create a product. And it's a funny slide saying, okay, that's what the clients ask for, okay, described it. But the project manager, he described, let's say, a tree swing, okay? The project manager, he understood something, okay, the technical project manager. Then the designer heard from the project manager what's required, and he drew a design. When the programmer arrived, that's what he had in mind, swing on the tree. What's wrong with that? It's a swing on the tree. But then the salesman, he marketed it in an all different way. And this, a lot of time, describes what happens when there's no one product manager that keeps all the, let's say, all the dots aligned and synchronized. And it's always nice slide to explain what's going on when it's not there. By the way, referring to Ilan's great presentation before, so the RED application, which is again a very great success, it took some time to develop. And one of the reasons it took times and things went right and left is because there wasn't there this function that could see the product from end to end.
So I like the most the designer thought about it.
Yeah. Yeah. I think this is maybe that. Oh, yeah. Okay. So going forward, product development process is very methodological process. Okay, you go to books. It has all these stages. I'll go through them, but then it's going to be a bit like methodology. But then I'll show you how we demonstrate it, how we do this in Maccabi in a real product. So we start with discovery phase. This is where the ideas come up. This is where we focus on research. That's the diagnosis phase, interviewing the users, identifying the pain points and all the problems that comes up during the talk. We analyze the data. We speak with the commercial part. We plan ahead, thinking strategically where we can go with this product. Wait, I'm working. 1 second. Okay. Once the research is completed, we go to the part of the product definition. This is a critical phase, very, very important. It takes time, usually takes long time, and involves diving into all the smallest details. So we try to think of all the different end cases, all the different details before we even start programming one piece. We prepare a business plan. This is when we go deeper into the business plan. A lot of time it's about money. We prepare the roadmap, which is a more strategic vision of the product. We put together something that we call MVP, minimal viable product. We're saying, okay, we see the strategy, we see the whole product. We want to say, okay, what is the minimal piece we can start with that will bring value to our users? We want to start with minimal as possible because we don't want to invest a lot of money in programming and development before we even see that it works, okay? And this planning doesn't happen in a vacuum. It involves interactions with future users. In this stage already, we talk to our users. It's usually doctors and other clinicians and therapists at Maccabi, and we consult with them. What do you think? This would work, not work? We show them mock-ups, pictures of what we plan to do. We get the feedback. Ideally, if we can, we even get them try out the product, something not very ready, but just try it. What do you think about it? Tell us your impression. And we always want to hear everything. The next stage after this comprehensive planning, we get to the execution itself. This is where we design and we develop. This is the programming phase. It includes also validation. Very important part is the user acceptance testing, which means that not only technical people, the QA teams are testing the product, but also real users. Those users that we spoke with at the beginning, we give it to them. Try it. Tell us what's wrong. Does it work well? Okay. And the final stage is the commercialization, the launch. And it's not the end of the product lifecycle, it's just the beginning. Okay, this phase is also very critical. Oh, sorry, 1 second. It's also very, very critical because you can develop a great product, but if you don't commercialize it, if you don't do the go-to-market strategy correct and the implementation within the users, you can miss the whole point. Once the product is launched, many people assume, okay, work is done, we're there. No, it's not true. It's a new phase that begins, one that includes a continuous monitoring, continuous improvements, and the evolution based on the user needs. It's all called product lifecycle management. So it's ending here, but it's not really ending. It's just going forever until the product, let's say, dies, finish. Sometimes this happens too. Okay. So I want to tell you about a product journey at Maccabi, a drug-drug interaction system that we put into Maccabi. And I'll tell you about the process we've been through along the way. So the subject of drug-drug interaction is a very painful and complex challenge in medical management systems, always, for physicians, for pharmacists, for any other therapists that get across medication dispensing to users. And I'm sure you all know about this. This can lead to hospitalization. It can because of adverse drug reactions, and it in extreme cases also death. And the setup point at Maccabi decided to put together a system that will alert the user, usually a physician, a doctor that prescribe drugs, when there is some kind of interaction. So Maccabi went out for a tender and chose the company called Signal. And Signal is an Israeli startup that created a highly advanced product that identifies drug-drug interactions, as well as interaction between the medications and the patient's clinical parameters, such as hypertension and others. And by the time this product, Signal, was introduced to Maccabi, the system was already being successfully implemented in several major hospitals, mainly in the States, but not only, and demonstrated both reliability and effectiveness. So we came to the product and we said, okay, we get a pretty mature product. We just need to put it into Maccabi. It should be pretty easy. During the research phase, the problem was identified, and we identified our main client, our main user, as the physician that is prescribing medication to a patient. But they don't always have the full picture in front of them, and the information about the medication that the patient is taking, or all kinds of potential interactions that can be between drugs. The doctor in front of the patient cannot always remember everything, and that's how we define the pain. The doctor is prescribing a medication and needs the system to alert him if something is wrong. And we want the system to be proactive. So we place the action of the system at the time of the prescription writing. Okay. So based on this, we started the process here. Once the prescription is written, the system, the EMR of Maccabi, the clicks, if you know it, it sends to Signal a list of parameters. It includes all the medications the patient is regularly taking, additional medication that the patient may have been purchased at Maccabi Farm, that we have this information, even though it's not a prescribed medication, any other medication that he bought. All kinds of clinical parameters that could affect drug intake, such as kidney functions or other medical conditions, for example, pregnancy. We have a pregnancy registry, so we also send this information because it can influence the medication that is allowed to be prescribed. The next stage, in case this is all sent to Signal outside Maccabi, Signal is doing the calculation, and then in case there is a severe interaction indicated for this patient, a screen pops up to the user, to the doctor, and he must take action. He cannot go further with the prescription until he take action, and he can either modify the prescribed medication, remove a drug, change it, adjust the dosage, or acknowledge the alert and saying, okay, I reviewed it, I know the clinical situation, and I still decide to override the warning and proceed with the prescription. Okay, so the doctor can say that it's his responsibility, and once this is resolved, the process continues and the prescription is generated out. It's important to understand that Signal screen does not appear in every case. So only if there is interaction, and only if the interaction is critical and defined by Maccabi's pharmacists, that it is critical, clinical pharmacists, to say this needs immediate attention of the doctor. It cannot be prescribed just as is. Okay. Because of that, we provided the user not only this pop-up that jumps when he writes the prescription, but also an option to start the calculation of the interactions, not during the prescription process, just when you go into the file, patient file, you can press a button and say, okay, tell me, what's the situation behind the scene for this patient in terms of medication alerts? So this was also added, but it's not the main flow. Okay, so one of the key strengths that Signal, the startup, proudly emphasized was its drug interaction display screen. Here you can see the screen that Signal invented. It's very, very sophisticated screen. You can see here the different alerts that pops up, and these items here, bars, show which drugs actually contradicts and is problematic to take together. When you mouse over this line, you can see the different options. You can either delete this drug, so it won't interfere here, or you can change dosage and other things. And it has a lot of options, because you can also see what diet you should tell the patient to take when you take a special drug, etc. And this is a complex interface, contains a wealth of information, and very, very smart tool for managing interaction and managing, the medication file for a patient. Signal even registered a patent for this specific screen. Their patent is on this screen, specifically that's saying it's a unique method of presenting interaction, and they have a patent on it. So no other company can copy this screen. Okay. So we proceeded to build the integration based on the process I showed you, and the scenario that we researched and decided to go through. And at Maccabi, we developed a very interesting, I think, good structure process for user exposure through the pilot program. Okay, so we recruited a team of physicians and caregivers who volunteered to be the first to try out the tools and products that we build and to share their feedback with us. Here you can see just a ad that we went out with when we started this program, when we have more than 300 physicians, and not only physicians, also nurses and other therapists as part of this group. And everything that we develop first go to them for a trial. So we opened the system to a group of pilot physicians. There were a few tens at the beginning, like 40 or something like that. We also prepared, we opened a WhatsApp group. That's how we communicate with our pilotists, as we call them. And we gave them the system. We gave them some very light instructions because we want to see that they understand what to do. And we could hear their feedback directly in the WhatsApp group. Not only the feedback that we got in the WhatsApp group, we also looked at the data of the pilot. And the results were challenging. After several weeks of working with this amazing screen that I showed you before, the one that is patented, the more 74% of the user reported that the system was complex and unclear. They couldn't understand what to do well enough. They found it very hard to work with that screen. And when we dig deeper into the data, and this is just an example of how we present the data that we dig into, we identified a particularly concerning phenomena where physicians entered a loop while trying to manage an interaction. So the interaction popped up, they're trying to do something to change the drug, to change the dosage, to dismiss it, but it closed and then it opened again. So they didn't really understand, and again and again. And here we can see 5 times the screen opened for a physician while he was trying to prescribe something. And even in one of these cases, we called the doctor and we asked, listen, we saw that you're having issues. What happened there? And she said, I couldn't change it. I couldn't understand what to do. Doesn't matter what I tried. And the worst thing would say, eventually I just gave up and I didn't give her the drug. And this is a very red alert for us as product. Something is wrong. Although it's a very good startup and it's been implemented somewhere else, for us, something is not working. Okay. So we went into discussion. We went back to our putting things together, and we came with few conclusions. So first, Signal's impressive interaction screen is complex and very hard to, it's packed with a lot of details, and it's hard for our users to deal with. We understood that the clinical scenario in community clinics is very different for what happens at hospitals. In hospitals, the documentations many times, not, or most of the times, not typically done in front of the patient. But after meeting the patient by the bed, you go back to the computer. The patient is not sitting here just by you, and you write the prescriptions. You don't have time, you never have time if you're a doctor, but you have like more patient or time to deal with this screen, and you're more flexible. In contracts in the community clinics, and part of our research was actually coming to sit in clinics by the doctor while he was handling a patient and trying to work with the system. And what we observed is that the story is different, okay? A visit is usually sometimes between average of 5 to 7 minutes for a visit in let's say, in a family physician, okay? So within this short time frame, the physician need to explore all these rich details and features offered by the screen, and it just doesn't really work, okay? Instead, they need something else. They need something more clear, okay? The third thing is that we found out during this pilot is that the interaction alerts often cause a lot of frustrations, okay? It triggers feelings of frustration and anger. It's not always easy for a doctor to be told, oops, you might have been mistaken here. Please take another look. And through this pilot and the user research, we kind of refined the community clinic scenario. We said, the patient enters the room, the physician interviews and examines the patient, and during this examination, the physician already has in their mind a fairly clear idea of the diagnosis and also the treatment plan. He already kind of knows what it's going to register, okay, to prescribe. And at this point, only then, very, very close to the end of the visit, so the diagnosis and the treatment plan already in his head, he needs to go back to the EMR and write everything down. And just before the patient leaves the room, this is where he puts in the prescription medicine. And this is exactly when the system stops him. What? I already have to, I'm done. I already have it in my head. What's jumping now? And the conclusion was that we must create something more concise, okay? We need to do better with the screen that pops up and annoying, frustration, and that was our conclusion. In this point, this is something very important that I want to emphasize. It's a very important thing for product manager, not to fall in love with ideas. So we had this great screen. We couldn't understand why it doesn't work. But the most important thing is to stay open, okay? We must remain open to alternative, to the feedback coming from the users throughout the entire product lifecycle, and not to be overly attached to a solution that might have seemed ideal at the beginning, but reality say different. So we had this and we said, okay, we don't have to go this way. We understand what doesn't go wrong. Let's put together a better product for our users. And we came up with this. We developed a new screen. We called it the simple screen. And remember Ilan saying, keep it simple, keep it simple. That's the best thing to do always. It's a more focused and it presents the interactions requiring immediate attention in a very clear and concise way. You see each alert is just in front of you. We also kept the immediate actions to be taken very, very clear. So it's not a mouse over or something hidden. You don't need to look for it. It's very clear. You want to find an alternative for this drug. You want to see more drug info to understand what's happened. You want to remove it, or you want to bypass this alert and goodbye. Okay? Very, very clear what you need to do. You have 1, 2, 3, the alerts that's coming. And we introduced this new screen that we developed at Maccabi to the startup, to Signal. And I must say that they were amazingly open to say, okay, we understand our screen, patented great screen, doesn't work for you. Of course, we presented this only after we checked it. So we took the screen, only the drawing, okay, it wasn't working, and we showed it to our users, to our physicians that had the problem at the beginning. We said, what do you understand from the screen? What do you need to click? We created this demo that you can, it's not really working, but you can click and it's like playing, okay? We call it a mock-up. And they played with it and we saw that it works. They understand. We created all kinds of screens and it had very, very good grades there. And they said, okay, we'll go for it with you. Must say that we also retained the full screen, okay? We just renamed it. We called it the expert view. So the user can go back and see this all full screen, which is, by the way, very, very efficient and useful for the pharmacists. So the clinical pharmacists, they do find that major screen, very convenient. They go into deep and they analyze if they change this drug, what happened. If they change this drug, what happened. So they have more time to explore the file when they do the consultation, the pharmacist consultation, and they do use the expert mode. But in most cases, in our clinics, where the doctor needs to quickly solve if there is an interaction and keep going because there are 10 people waiting outside the door, this screen wins. And by the way, the startup Signal, they embraced this screen officially into their product. And we didn't get any money from that. Okay, so we went back to the table with this solution. We started a second pilot. You can see the second cycle. So the first one was 20 people. The second one was, we had more confident. We had more people. And another iteration that proved to be very, very great success. The product adjustment demonstrated their value. This time we observed accurate and effective use of the system, and we ever received positive feedback. And so they said, oh, wow, it's clear, it's much better. And sometimes it really popped up very dangerous things. And people say, oh my God, I didn't know she's pregnant. It was just a digital request and she didn't say anything. But the system knows she's pregnant because she has the beta tests in there from a week before. So things like that. And from then we got gradually expanded. You can see here we had 3 cycles, 3 iterations of pilots, which we went through, and then we went to the widespread. Overall, the entire process for us took more or less 1 year from starting development to launch, which is very, very fast, including this change that we did in the middle and the new screen that we invented. However, along this process, we had another major challenge to tackle. Ilan talked about it also. So despite the fact that the system can save life and protect not only the patient, but also the physicians from making mistakes, it can still be frustrating. It interrupts the workflow. It prevents the prescription from being completed until the interaction is properly addressed. You cannot continue, okay? And like any other system, it sometimes makes mistakes or lack full context, and it can be annoying. And the way product teams deal with such challenges is what we call change management. So change management is also a whole theory and methodology, and there are many, many things that you can do when you put a product, even if it's annoying, even if it jumps in the let's say in the user's face and interrupts him. You can do a lot of things to minimize the resistance. To minimize this resistance, we focus on several key strategies. So first, early involvement of key stakeholders. So you heard me saying that just when we started, it was just at the beginning, we already been talking to our users, and not only to our users, also to the management. So the medical management of the different districts, we exposed them with the coming project. We told them about the difficulties that we're having, the effort that we're putting together to overcome all these things. So they were part of this from the very beginning, okay? We communicated very early the value of this system. So really there were let's say cases where we had thank you letters from physicians that said, oh my God, thank you, I forgot, I didn't put attention, I didn't saw this, and it jumped and it saved that. I was so tired, I could mistakenly prescribe it, and the system just saved the situation, saved the patient, saved me from doing such a mistake. And every doctor that it happened to him only once, okay, he felt this way and appreciated the value that this system can bring. Okay. We provided training and support. So yes, we should do systems that doesn't need any training, but if there is someone that wants to know more to understand better, we put this training available for them. So we had a we have a webinar running. It's still running, by the way. This went up like 3 years ago, and it's still running. Every month there is a webinar, and physicians connecting. They can also see it, recorded, but it's there. We have a movie showing what to do, where to click. We have short movies where you can ask a specific question. How do I find alternatives to a drug? And it pops up in the library, and any other kind of training materials you can think of. We created the feedback loops, and we listened very, very actively. So everything is interesting. Every feedback is relevant, even if it's not pretty. Okay, which is like, okay, so it's not pretty, but still, if it's not pretty, it means something. It means that you're not feeling attached to this system. You're not feeling comfortable with it. Let's talk about it. What would make it better? And when you listen and your users hear it, they feel it, and they gain the trust. They gain the trust that the products that we do, we don't just do something to win a, I don't know, a record. We do it to solve their problem, and if it doesn't work, we want to hear about it because we will improve it. Okay? And this is very, very important. Okay. I also would mention another small thing. I see I didn't write it here, but another thing that helps throughout this long process of change management is celebrating the success of little things. So, for example, if we have a story of someone saying, this system saved me and had a great thing, a lot of time we just take this, we take a video, or we put the quote and we send it out, and it's a very good thing to keep the pace going and the good spirit around developing the product. So everyone together in this. It can have bugs. It can not be the best thing just on the start, but we will improve. But we're all together in this process of product development. So to conclude, this was just one example of a product in our team. Of course, we have many, many other products. I want to share with you 10 rules for designing great products for physicians and clinicians. It's all, let's say each one of them was learned the hard way through real life experience. So you must know that in healthcare, doctor's time is counted in seconds, not hours. If you add 2 more mouse clicks to a process, you've killed the process. If you remove 2 clicks, you won their hearts. Most clinicians, I'm sorry to say it, are not early adapters. Okay? The vast majority are not early adapters. The value must be very, very clear from the very beginning and first use of the system. If there's no wow effect, or worse, if the process slows down their workflow, there are great chances that the product won't be used. And doctors struggling with technology is a red flag for the product team. And this is, by the way, what we got on that product that I showed you. They were struggling, and we stopped after 20 users. We said, okay, something's wrong. It's not good enough. Pop-ups are only for critical alerts. Okay, so the startup company, the Signal, they wanted to pop up for all the alerts. Also pharmacists, by the way. Listen, it's better. It will be a more optimized drug, but we know that alert fatigue is a real epidemic. Okay, it's thinking of adding a pop-up. Think twice. If you still decide to go for it, think twice again. Pop-up should be reserved only for critical medical situations. I know the situation is not like this in the EMRs that we have today in Israel, neither in the HMOs or in the hospitals. But going forward, the future looks different. Less and less pop-ups. Keep it simple. You heard it many times today. If the product requires complex guidance, you must be trained before you use the product, it's not a good product. We have a problem. It's probably too complex, and the process must be very intuitive, like if you are using an iPhone. 5, show, don't just tell. So there's a huge difference between presenting a product to a physician at the idea stage, as you should be doing, even as a mock-up, as a drawing, okay? Or as part of the actual workflow in the clinic, than just telling them about it. You need to see the screens. It's true for everyone, but for any user, okay? Don't say, we asked the doctors. Don't say, we ran a survey. When evaluating a product, show screen images, or even better, the software itself, even if it's not perfect, just let them hands-on try it. And it was 1,000 words. Test group. So that's the most important thing I would say. Begin with a small group of enthusiastic clinicians who want to be part of the process. Choose those who will give feedback, refine the flow, and help sharpen the product. And stay closely connected. Make sure they feel the value of their environment. If they feedback something, get back to them and say, okay, I hear you. I'm checking this and I'll get back to you. And even if you decide not to do it, not to change, come back and say, listen, we thought about it. It's too complex. We decided not to do it. Never give them to wait on the air. I saw you this special mechanism. It's amazing. By the way, it's something that is only at Maccabi, as far as I know, in the HMOs. I don't know about hospitals, but it works very, very good. Stories told by data. So we have in our department at Maccabi, we have this sentence on the wall: in God we trust, but all others must bring data. Some things you don't need to ask. You need data, okay? Data is the gold of product management. You must ensure that you have the data. You don't always just have it. You must ensure to keep it. So when we put the system on, every click, we take it down to our database and we start to analyze it, what's going on there. So this is another one. 8, user experience always wins. UX, user experience, isn't just for patients. Usually HMOs, they invest a lot in the patient's application, Kabi, Clalit, they has these very fancy applications, but also physicians. They need to have good experience. If the experience for the physicians is poor, the patient's experience will suffer too, okay? And remember that product management is a profession. It connects the stakeholders. It brings in the experts of user experience, and never compromise on it. It's an important part of the planning. Change management. So as you can see in this slide, there's never a good time for change, okay? They were too busy with this wheel, okay? So no thanks. And there's just never a good time for a change. But if your feature, product change the workload of physician or the organization, if it's relying on a shift in how things are done, you need to consider the impact, and you need to plan the change management process. The product design must account for real processes. It's not just ideal ones, and there's never you can never go too far with change management. Always do whatever you can for that. Tell everyone, share everything, create the materials to go out, tell the story again and again and again, and it works. And last but not least, probably, although it's my last slide, is that launch is just the beginning, okay? It's the beginning of a wonderful life of the product. The product continues to grow. You must keep monitoring, keep improving. It must happen all the time. If you don't do it, product get outdated. Product gets not good products. And it's even more it's more demanding now in the AI era, because AI is something that you need to validate the whole time. It's not only one-time validation. You need to watch the data, watch the where the algorithm goes, and it's just an ongoing thing. So also it's something to remember. You go into a product, you go into a project, you need to remember that it goes up, and then you need to keep taking care of it. So that's my last slide, and I left a few minutes for questions.
Thank you, Noor. Thank you. Amjad?
I'll stop sharing. Yeah.
Amjad? Yeah.
Okay. Thank you, Dr. Noor.
Thank you, but just saying I'm not a doctor. I always saying I'm a doctor for computers, so I try to.
Okay. So I have a couple of questions. I led a team who developed a system like this, clinical decision system, and DDI was part of our features. So my first question, why you didn't bring or brought a ready system instead of developing this from scratch? Maybe this will cost you less than building a new system. So this is my first question. My second question, what about the effort estimate for building something from scratch, neither bringing this as ready, and what is the impact on the timeline? So effort estimate like from brainstorming to technical efforts to project management effort, developing, go live, training, etc.
So maybe I wasn't clear enough, but Signal, the system that we brought, was a ready-made system. It's a startup, an Israeli startup, who created the system already. And our goal was to put it into process in Maccabi. Okay, so we took their system, the calculation, all the calculation of the DDI itself was their startup. Okay, also the screen that popped up, it's their screen. But what we did is a product management process where we made sure that the process and the product that we chose the product, okay, fits our users and our processes and their specific pain and needs. And this time it was created in advance, and indeed it took pretty fast, 1 year. However, we do build now another CDS for clinical alerts, okay, and not DDI, but clinical alerts, patient, let's say all kinds of health population alerts and things like that. And we do create the rules by ourselves, but still we buy a system, an engine, a rule engine, where we can easily put in the rules. So there is a clinician saying, okay, every patient with this kind of blood test, alert the doctor that he needs to do another test, okay, or another, I don't know. Okay?
It's like a clinical guidelines, you mean?
Yes.
Yes,
so in this case, we do it ourselves, but we don't do it from scratch. We buy an engine that can fit for us to create the rules, and it push the rules into the EMR. So you're right that building from scratch many times is longer than just buying something ready. But in this example that I showed you, buying something ready doesn't always fit as is to your organization, okay,
Correct.
to your processes. So
it should be customized, yeah.
Yeah, so it's really a case by case to decide if it's something to buy and adjust or something to create from scratch. Usually we create from scratch only very small features. We are not a software company, Maccabi. We are HMO, okay? So that's...
Okay, and what about the effort estimate and timeline for, like, for example, you integrated with this software. So how you applied the effort estimate from integration to pilot phase, training phase, and so on?
So it's also part of the, the expertise to know, to examine the software, to examine the process, to examine the magnitude of the whole flow, and to estimate it. We put buffers. For here, it took 1 year plus minus 1 year. It's very, very fast and included everything. But this is a fast project. Listen, so it's Maccabi, but I know it's also in other HMOs and a lot of health organizations in Israel. The systems are very, let's say, legacy systems are old and not very advanced. So every integration takes a lot of time. So that's something to start with, every integration. So you need to try to minimize the places where you need to integrate. It's better if it's only one point and not a lot of points, and things like that. And most of the projects are heavy. The estimation, again, it's about coming bottom up. It's about experience. You did already such kind of projects. You know how much it takes, more or less. You put some buffer, and also buffer for the cost, of course, because always something happens. There's bugs, there are malfunctions that you need to take care of. So it's part of the, it's part of the profession. Product manager should know how to do it.
Thank you.
Thank you, Ashraf. Rula, questions? Yes, Rula. You are on mute, Rula.
Now you can hear me?
Yeah.
Yes.
Thanks. Thanks, first of all. I have two short questions. First, which reference system does Signal rely on? Sometimes I see drug interaction flagged in UpToDate, for example, but they don't appear in Signal.
I don't remember by heart. I think maybe Micromedics. Maybe. I'm not sure. I can find out for you if you want. I don't remember. But they rely on, public world-class databases. We did have to do some localizations, so not all the rules that come from the global drug interaction databases apply for Israel or for Maccabi. So the pharmacists at Maccabi, they do have a control of what will jump as an alert, what will be a severe alert, what we need to do some translation into local name of drugs. So there is a phase where the pharmacists at Maccabi, they control the content itself as well. Okay, but if you want, I can find out and send you.
Yes, it's very important. And I have another one, if you may.
Yes, Rula. Okay.
When the patients renew their medication automatically, does the system still check their last lab results and alert the doctor? For example, if some patient develop kidney problems, would Signal flag the need of the dose adjustment?
I don't remember by heart, but yes, Signal does get the lab results as part of the parameters. We need this specific interaction, so we can check what jumps, but they get lab results. They get they don't get
when the patient renew their medication automatically.
There's no automatically, it goes to the doctor.
Yes, it should go to the doctor.
Okay, I think that is.
But the doctor then, if something changes, it jumps for him.
Okay.
Even though the doctor bypassed the alert, let's say the doctor say, okay, bypass the alert, I don't want to take account. If something in the meantime changed in the lab results, etc., the bypass is overruled. Okay, so because the environment changed and it should be popping up. If you see things that not popping up, I suggest you send it out. There's a little envelope at the Signal, and you can send your feedback there, by the way.
As far as I remember, I use Signal, but in Leumit, And we have like this kind of alert according to blood test.
Yeah, it is in Signal.
Yes.
I think they can call Habit 3555 and they can make it by themselves. So, for example, to renew the medication.
I'm not
Without-
familiar with this, but then no, 3555 they don't use Signal.
Okay. I will check later.
Thank you. Noah, thank you very much. Leila, okay, last
Thank you.
question, 1 minute. Yeah. Galit with us here. Yeah,
Just
okay,
a quick,
1 minute.
it's
Yeah.
a quick question because I also wondered about the feedback loop that you talked about and how users' experience is always win. And I was just wondering, what is the best way for like early stage health tech startups? I think a lot of us also too. How can we build those loops when our users are so different? Like we're talking about patients, insurers, and healthcare providers. How can we balance that, especially at the early stage? Thank you.
So this is very product related. So at the stage where you define your product, you need to clearly define your targets. And for each target, there should be a very specific audience that you're aiming the product to. So as part of the MVP of the minimal viable product, you should say, I'm putting this feature together. It's for family physicians in the center of Israel. I mean, you need to be very specific and start with this and find some physicians that want to be part of your discussion and get them engaged, show them and get the feedback, and then it gets to more cycles. You need to start very small. Okay.
Thank you so much. Appreciate that.
Noah, thank you very much. Thank you.
Thank you.
Galit, thank you. Appreciate it. Thank you. Galit, yes.
Yeah, I'm here.
Yeah.
Okay.
You can yeah.
Can I do a share screen?
Yes,
Can I
yes,
share
you can press, yeah, sure.
Okay. So just a second. I didn't want to screen.
ظافر متأسف ما انتبهتش على سؤالك، هلا انتبهت على السؤال، متأسف جدا.
لا بسيطة بس بشكل عام يعني أنا كنت بدي أحكي شغلة، خصوصا إذا كنا نحكي في السيشن الأولاني عن موضوع اللي هو الانتربرنور بروجكت، وكمان هون عن البروجكت مانجمنت. يا ريت يكون في هيك سيشنز لأنها كثير مهمة، الوقت أطول لموضوع الأسئلة.
رح نعمل
لأنه
على
صراحة كلياتنا ما عندنا أسئلة ويعني
I'm sorry.
No, not yet, Galit.
No,
sorry for
not
the
yet.
interruption.
No, not yet.
Okay, continue. So and just tell me when you see
بتساعد
it.
سمول لمعلى، بتساعد سمول لمعلى قليل.
بتساعد سمول لمعلى.
والله بالإنجليزي يمينة.
بدي أقول لها إنه اليوم يعني السكرتارية اليوم
أنجليت يمينة.
אני בצד שמאל למעלה וגם היא ימינה.
באנגלית ימינה, כן.
בערבית זה אותו דבר, ימין נכון? אותו דבר.
אותו דבר, כן. ערבית בערבית.
ימין ושמאל.
ימינה, שמאלה, אין תמام.
אנחנו נגיע לזה בסופו, עד 8 אנחנו נגיע לזה.
בסדר גמור.
בצד הכפתור האדום.
תמשיכו, continue.
בצד לי, הכפתור האדום.
Usually work with the Zoom.
It seems it's totally different.
It's upright corner.
זאת הסיבה שאמרתי בצד שמאל, כי אנחנו רגילים לזום, אבל טימס זה משהו אחר.
Just a second. And do you see now?
Yes.
Yes. Hallelujah.
עצמנו, לא?
You see the screen that I'm sharing at the moment?
Yes.
You see?
Same screen,
Yeah, okay.
You need to open the presentation.
לא, תעבירי אחד כדי לראות.
Now?
No.
Open the presentation.
No, we do not see it. If I'm...
You are sharing the whole computer.
You are sharing the whole screen. You need to open presentation now. متسجل شبه.
Okay. We should have...
You are sharing everything. So you can open only the presentation itself.
Exactly.
Sorry for that.
Minimize this one.
So let me stop sharing and then reshare it. PowerPoint Live. Window. And now?
Yes.
Yeah.
Yes.
Department of.
Yes.
Yeah, okay, great. Hi, everyone. My name is
Hi,
Galit.
Galit.
Hi.
I'm the head of clinical research at KSM, and just by hearing Noah, I heard that you heard a lot about Maccabi Healthcare Services, and I think I will continue with that role and talk a little bit more about KSM. KSM is the research and innovation arm of Maccabi Healthcare Services. I think I'm the first one from our institution that is talking to you. But more importantly, I want to talk about how we are conducting clinical trials in HMO settings, which is what we are. I'm sure you are not just Maccabi oriented. You're just like talking all over the different healthcare in Israel and different HMOs. But again, as I'm part of Maccabi, I will zoom into our work. So firstly, about us, I'm sure you heard about it, but again, I'm so sorry for that. We are the second largest HMO in Israel, and we cover approximately 2 million members all over, almost 3 million members throughout Israel, with hundreds of touching points with our patients, hundreds of clinics, thousands of physicians and other healthcare professions. We are fully digitalized for over 30 years now. We are collecting data that is being generated by the physicians or the other healthcare professions that are working within the HMOs, and we are generated that data by basically doing every interface in the medical health system. So every interface that is being created with our patients is all being recorded and transmitted into one medical record. And on a day-to-day basis, it helps us to manage our population much better and to do a lot of proactive work with our patients. But as a research and health and innovation institute, it helps us to conduct a lot of research and development. So a bit about who we are. KSM is called Ka'an Sagol Maccabi, is the research and innovation arm of Maccabi Healthcare Services. It's the only organization within Maccabi who works with external startups, pharma companies, academia, and doing different R&D projects with them, different collaborations, using our data sets, using our electronic medical records, using our samples, and I will explain a bit more about that, and using our clinical trial departments. So if we look on our ecosystem, we work with tech companies, we work with pharma companies. Pharma companies, by the way, it's not just to conduct clinical research. We also do a lot of collaborations on different epidemiological research as well. We work with the biotech industry. We work with a lot of startups, and I just heard a bit before about how you develop, about the process of developing a product. We work with different academia partners, and we combine a lot of that data with other departments within Maccabi. So we are a part of Maccabi Healthcare Services, but we are like an organization within the big organization. As the entire Maccabi, we are not for profit, but like other departments, we are self-sustained. So it means every work that we are doing is being sponsored by one of those partners. And what kind of work do we do within our research institution? We are divided into different departments. First is the big data department. Here we are mostly working with startup companies that have a specific idea to develop a specific algorithm on early detection or prevention of specific disease, and they are working on our data sets to develop that specific algorithm. Alongside the startup companies, we have clinicians within our within KSM that helps the startup, that modifies, that knows how the data works, and together we're building it. Another big department that we have is our biobank. A biobank is basically like a bank of samples that we collect from Maccabi patients. If some of you heard of it, it's called Tipa למחקר, a drop for research. We basically suggest to Maccabi patients if they want to donate one of their blood samples to our biobank for research purposes. So when a patient comes to one of our laboratories and he's willing to participate, we offer him to participate within our biobank. When he gives away his blood samples, he will donate another tube that we take it and we store it within our biobank. And once a patient, a member, is signing an informed consent, obviously. It's not like we're just taking a blood sample without explaining exactly where it goes and what kind of research we are doing on it. We are taking another tube, again, every time that he comes to the laboratory, and we store it within our biobank. In our biobank, we process the blood and we convert it into different parts of blood. We divide it into serum, into buffy coat, into plasma, into DNA, and each of those samples is stored and is waiting for the right research to come. Every one of those samples is connected to the medical record. So it's not like we just have biological samples of a huge population. All of those samples are being connected to a medical record. And in that medical record, we can see all of the patient's history. We can see what kind of medication he is on, which kind of side effects he is reporting on, what kind of illnesses he has in the background. And for our research purposes within our biobank, that's a huge advantage. Another thing that we are doing nowadays is to sequence our biobank for more genetic research. Another arm that we have is the epidemiological research. In this department, we work a lot with the pharma companies that are trying to learn or to modify different trends within the health system. And of course, and this is the reason that we are meeting here today, one of the biggest departments within KSM is the clinical research arm, meaning the clinical trials. It might come as a surprise, but in Maccabi, in an HMO, you can do clinical trials. Clinical trials meaning to try to test a new component, molecular, or a device within subjects that are willing to participate in a clinical trial. We all know that a lot of clinical trials are mostly conducted in hospitals. A lot of people ask me why it's so easy, or why we are conducting more clinical trials within hospitals and not within the HMO settings. And to be honest, the answer is very, very simple. It's a part of the DNA of the hospital to conduct clinical research. And unfortunately, it's still not trendy enough, or it's still not implemented enough to conduct clinical research within the HMOs. But there are a lot of clinical trials or a lot of indications that can be within community-based clinics. So a bit about us, a bit about what exactly we are doing. We are the only one who are executing clinical trials within Maccabi. So for example, if we have hundreds of clinics, we choose specific clinic according to the indication of the clinical trial itself, and we conduct the clinical trial as a whole. I will explain a bit more or remind you a bit more about what exactly is a clinical trial, the phases, etc. So we are the one who's executing it. We are the ones who are working within the entire Maccabi organization. We are connecting between the pharma companies to Maccabi members, and we are the ones who are doing the clinical trials. And the doctors, Maccabi doctors, are the PIs, are the primary investigators, or the sub-PIs, the sub-investigators for those clinical trials. So with that, we are basically leading, innovating, and bringing within our organization the newest research. So if, for example, nowadays, everyone is on GLP-1s or on GLP-1s plus GIPs, we are not conducting within our clinics a new component that is not being tested anywhere else. And Maccabi members that are participating in the clinical trial have the first access to those new medications that are now being tested on advanced stages. Our team is, in our team, we have doctors, in our team, we have nurses, in our team, we have study coordinators. And again, every clinical trial that we are opening throughout Israel, we will send our team to do it. A doctor that is a PI is not on his own, and he has an entire team and an entire infrastructure that is behind them and helping them. So, as I said before, we work with pharma, and we are performing, as we speak, we are performing different clinical trials with pharma companies. The pharma company is the sponsor in multiple indications. We also perform clinical trials with startup companies. Startup companies is, in my case, in this case, is more small biotech companies that have developed an asset, we call it, or a component, or a device. We see a lot of startup companies that are developing a specific device that needs to be tested. And because in Maccabi, we are not just primary care, we also have secondary care. The indications that we can, the clinical trials in different indications can vary a lot. So for example, we can do a clinical trial in more family medicine, and we also can do a clinical trial in dermatology, in hepatology, in neurology, in different indications, as I said. And a lot of those times, we are performing multi-center research, which means we are not opening a clinical trial just in Tel Aviv, for example. We can also open the same clinical trial in Tel Aviv, in Jerusalem, in Haifa, in Eilat, in Kiryat Motzkin, and in other places, or El-Fahim, and to do the clinical trial at the same time in multiple places with multiple PIs or sub-PIs. At the moment, we have approximately 25 clinical trials that are running. So it is very impressive in multiple clinics. And again, I will elaborate about that a bit more. And we are doing clinical trials in different phases. I will remind you exactly what the phases are, but we are doing clinical trials in phase 2, 3, and 4. We are not doing clinical trials in phase 1 because of the complexity of a phase 1 clinical trial. Again, as we said, we have multiple researchers. It could be a neurologist, it can be a dermatologist, it could be a pulmonologist, very, very different in different places. And we have even a worldwide collaboration as we connect with different health organizations throughout the world and do co-clinical research at the same time. So just a small reminder for the ones who are not exactly, that do not exactly remember what is a clinical trial and what is, how it breaks down. So as we develop medication, as we develop a new product, but for this, for our lecture, we will talk about the medications themselves. We have 4 major different phases. Before we are doing the clinical trial on the patient themselves, there is a phase of clinical trials that we do it in the laboratory, in patients, in animals, or in the lab itself. It's an in vitro clinical trial or in vivo. In vivo means on animals. And after a molecule seems to be safe enough for in the laboratory, then we move ahead and we start to test it on human beings. The first phase will be phase 1, and the main purpose on this step of the development of a medication will be to test the safety, and safety again of the medication in human beings. Usually, phase 1 will be held in the hospital, in specific clinics, in specific departments, within the hospital. The patient that will participate within that study are usually healthy volunteer subjects that are donating their time and their bodies, basically, to see if the medication is safe enough for them. It's a crucial part, and we in Maccabi, we are not participating in it. I don't think any HMO is participating in this phase because it's very, very risky. And those patients need to be monitored all the time. So this is why it's only happening in the hospital and it's not happening in an HMO. As we go ahead, as we've proven that the medication is safe enough, we are moving ahead to the second phase of a clinical trial. After we will get a report from the committee, from the company, that checked that the medication, that the new component is safe enough, we will move ahead to the second phase of the clinical trial. Up until, I think, 2.5 years ago, phase 2 was not available to do within an HMO, within Maccabi. And then we've decided that we are gonna go ahead with it. We managed to convince our IRB. IRB means our Helsinki committee, plus Maccabi's medical management, that we are good enough and we are professional enough to start doing phase 2 clinical trials. Not in every setting, not in every clinic. Within Maccabi, as I said before, we have hundreds of clinics, but as we are divided into 5 different districts, within every district, we have special clinics that are more, let's say, emergency or more advanced treatment oriented. Within those clinics, we have like a daycare and mini emergency room that is being occupied by physicians, nurses, etc. throughout the day from 9 a.m. to 11 p.m. We have advanced CPR equipment in it. We have the crew, the team that is more professional, let's say. And this is a place where we decided that can be a fit to try, and not to try, we are doing it, to do clinical trials that are phase 2. And we are happy to say that we are, at the moment, we have like 5 different phase 2 clinical trials, and we already finished a few more that are phase 2. Phase 2 clinical trial is a bigger clinical trial than a phase 1. Phase 1 is on a very small amount of patients. You need a very small amount to prove that you are safe enough, and then you can move ahead and go and to continue the clinical trial. In phase 2, and as we go forward, the number of patients or subjects or participants that need to be a part of the clinical trial grows. So on phase 2, we have like at least 100 subjects that needs to participate within that clinical trial to see if that phase is good enough, and we can continue with the development of other phases within that component. So the phase 2 clinical trial, also same as 1, is to prove firstly the safety of the medication, but now with another thing to it. At phase 2 clinical trial, we need to prove that it's safety, yes, but we need to establish what is the max dosage that we can give to a patient without creating any side effects. The bigger the dosage, and it's not a mistake, the bigger the dosage with the low side effects, the max dosage we can give out of that component without creating any side effects to the patient. In a lot of those clinical trials, we will see that they will divide into 3 or 4 arms with different dosage of the same component, of the same medication. Again, to measure what is the max dosage you can give to a patient without developing any side effects. And in this case, it's not one of the goals of the research, but we are starting to get a sense of if the medication works. I have to say that most of the clinical trials are ending in this part. A lot of medications are not continuing to a phase 3 and to a phase 4. And this is where they stop. So in order to prove, we will have to test it on specific amount of patients. Usually the inclusion criteria are very, very, very strict. The patient will need to undergo a lot of screening tests. For example, we have multiple, but one of the clinical trials that we are doing now is on fatty liver with a new component, and a lot of companies are into fatty liver, and a part of the screening just to see if a patient will enter the clinical trial is performing a liver biopsy. So we, as Maccabi, we do not do a liver biopsy within our organization. Obviously, we do not have biopsies that we are performing, but we connect, or we do negotiations, and we do joint ventures with hospitals, and they are performing for us those very complex procedures that needs to be done as a part of the clinical trial. But I'm just saying that a liver biopsy is just a part of a screening of a patient before he even starts the clinical trial itself. So a lot of the patients will undergo a biopsy, for example, biopsy, MRI, and a lot of other procedures, just to see if they can be a part of the clinical trial itself. And most of them, I mean, we have like clinical trials where the screen failure can go up to 90%. And still the pharma companies are willing to sponsor a lot of those stats, and every activity that is being held with the clinical trial, it all has to be paid by the pharma company. Nothing is being transferred into the HMOs. Everything is being paid by the pharma companies, and they are willing to do it just to prove or just to have the correct patients in the clinical trial itself. So after we finish the second part, or the second phase of the drug development, again, most of the clinical trial will end at this part, but a small part of it will continue to the third phase. And this is the part that we enjoy the most and we love the most within the HMOs, and not just the HMOs, also the hospitals. The phase 3 clinical trials are much easier. It's not really easy. I mean, to perform a clinical trial, it has a lot of stuff that needs to happen, and everything is very, very, very strict. And I will explain a bit later about it exactly. We are very, very, very strict, but still it's the phase that is more easy to recruit. The patients, we have a lot of evidence. It's easier to convince the patient, the doctor, and the organization, because we already have a lot of data that the component is safe enough. And this is where we can recruit patients, Maccabi members, much easily. And usually the numbers that Maccabi or other department or other hospital gets to recruit in this phase is much bigger. If, for example, if in that fatty liver clinical trial that I was talking about, the entire Maccabi, all this huge organization with 3 million members, had to recruit specific amount of patients. We were supposed to recruit only 2 to 4 patients. That was our aim. That was our goal that the entire Maccabi got. But in phase 3, we're talking about much bigger numbers. It can vary from tens to 100s to thousands of patients. Usually the phase 3 clinical trials are long. Most of them are long, minimum 1 year, and they can go up to 5 years of clinical trial. Clinical trial means all the patients are recruited. They will need to come for a procedure. They will need to report their outcomes. They have a lot of visits. It's a very, very strict thing that they need to overcome. And the retention rate is, I think, one of the most challenging things within clinical trial as a whole is the retention of the patient, especially in 3-year, 4-year, 5-year duration of a clinical trial. And let's say that the pharma companies invest a lot of money and resources in the retention of the patients within a clinical trial, and we Maccabi as well. And first, we do see it as easier for us to retain our patient because from the beginning, the clinical trial is being held close to where the patient lives, with the physician that the patient already knows, and he has established this relationship with him. And I don't need to tell you that, but patients rely on their physicians. The patient rely on their doctors. So it's much, much easier for us to retain the patients and to recruit them. In general, our recruitment strategy is very, very, very different from the recruitment strategy of the hospitals. Because remember, I'm the HMO. I have the patient's record. If, for example, I need to recruit patients with Parkinson's disease or a new drug, a new medication in Parkinson, I can go to my EMR, to my data analyst that works with me within KSM and ask him, please, I want to create a query. Please find me all the patients that have been diagnosed with Parkinson at the last year, and they are being treated with this and that, and their blood analysis from the last year was this and that, and they weren't hospitalized in the last year at all, just because these are the inclusion criteria of that specific clinical trial. And that specific ability is something that the hospitals are lacking. They do not have the same data sets that we have, and their ability to find the correct patients without having access to their medical record is very much different from our ability to target the specific patients that we need. After phase 3 clinical research is over, after years of development, this is where the medication goes to market. This is where we get an FDA clearance. This is where a drug is being released to the new world, and all of you are getting a visit from a pharma representative trying to convince you that the new medication that the pharma company has developed is the biggest new thing for the patients. But for us, for the clinical research department, the work is not over, and a lot of the clinical trials that we are asked to lead is a phase 4 clinical trial that, by the way, is not mandatory. Is not mandatory in the world. The purpose of phase 4 clinical trial is to see how the medication acts, how the medication is being taken, and how side effects are being represented when we take out the very controlled world of the clinical trial. And the second name, or the real name of phase 4, is real world evidence-based study. And this is where I want to extend a little bit. I mean, clinical trials in general, we need a whole course, but I was asked to talk as fast as possible in 1 hour about the clinical trial, so I'll just try to keep the most important part of it. So phase 4 clinical trials is a very important phase that mostly being done within the community settings, because the patients are in the community. They are not in the hospitals. As simple as that. So when we talk about real world evidence, I want to divide between real world evidence, that's the right bar, into RCT. RCT, when I'm saying RCT, I mean,
Randomized trials.
Excuse me?
Randomized clinical trials.
Exactly. Randomized clinical trials. So the settings in the RCT is experimental or interventional setting. We build a setting to have the clinical trials in it, we want to do a research within Jerusalem clinic, we need to build the setting in it. We are not an hospital. We do not have a department, and with that department, we have all the resources. We don't. We still need to remember that we are an HMO, and even if it sounds unreasonable that we can make it, we can, and we manage to prove that we are. So in the RCT world, we will need to build the clinic for clinical trials. We will need to have there a specific refrigerator, a centrifuge, we need a lab, we need a pharmacist, we need specific stuff in order for us to have the clinical trials, the randomized clinical trials, where in the real world evidence, we do not need to have a setting. Okay? We do it as a more observational or non-interventional setting. For example, when we want to say a real-world evidence, we still, and it's a clinical trial that is a real-world evidence, it's a phase 4 clinical trial, we do need to sign a patient to participate in that specific research, but we cannot do any intervention in order to bring the patient into the clinic. If in RCT, we need to do work, we need to find the patient in the database and to summon him to come to the clinical trial. In the real world, we cannot do that. We need to wait to that specific patient to knock on your doorstep, and you as a primary investigator or a staff PI, doesn't matter, will remember that you are a researcher in that clinical trial, and you will offer the patient that from that point on, yes, there is a new medication that can fit him amazingly. It's already been approved. But now the difference is that you will take the new medication and we will monitor you throughout the time. You will come for a visit or two, or maybe even not. And we just will have access to your database, or we will just call you every 3 months to see if you have developed any side effects. This is the main difference. So this is the main difference. We cannot do any intervention with the patient in real world evidence clinical trials. The study in RCT is based on a protocol, while the real world evidence, you do not have a protocol. You cannot control if the patient is receiving the study drug at 9 p.m. each night, or if he's taking it with other medications. You cannot control. The real life is something that we cannot control. The treatment is also different. Fixed pattern versus variable pattern. Again, we cannot control with which medication the patient will receive the patient. While the RCT is very, very, very strict. We have a study protocol. A study protocol, it's a book of guidelines, and you cannot move 1 centimeter from what's written in the study protocol. In a way, it's very, very easy because you just need to obey what the protocol says. But in other cases, especially as practitioners, I mean, I remember I've been told at day 1 at school that we need to improvise, that we'll be good when we need to think differently, when we need to improvise. We need to forget all about it when we are dealing with clinical trials. Clinical trials, the RCTs, the randomized clinical trials, is a closed set, is a closed box, and we need to be very, very specific with the things that we are doing. Obey by the rules, by the book. And every thing that is happening outside of that book needs to be reported to the Helsinki committee and to the company itself. So again, very, very strict versus very, very wide. Same with the inclusion and exclusion criteria. In the real world evidence, there are no criteria basically, except for if the patient really deserves the medication itself. We refer in randomized clinical trials to the primary investigator as an investigator, while in the RWE, practitioners, which is what you all are, okay? In randomized clinical trials, we will compare the new medication to a placebo, or if not a placebo, to another medication that is available in the market. Not all randomized clinical trials are being tested against a placebo. It can be placebo slash the best medication that is available on the market. And then our goal, the entire goal of the clinical trial, is to see if the patient will have at least not inferiority, if not superiority over the existing treatment that exists. Okay, so while the RCT will check the efficacy of the medication, in the real world we will check the effectiveness. And obviously there is no randomization in the real world evidence. And what do we benefit? What the HMO or what the world benefits from those kind of clinical trials? So in a way it goes without saying, but those studies are the main cause, the main reason of those studies is to evaluate the natural history of disease, the prevalence, the incidence, the unmet medical need, the current treatment patterns, and the standard of care. They can be used to support patient outcomes and health economics. They are used to understand current healthcare services. They are not, again, they are not RCTs. They are not randomized clinical trials. And they can be performed on high-risk groups, which usually the randomized clinical trial won't be used on high-risk groups. So as a system, it's very important to engage in those activities as well. Again, it's not mandatory. Not all pharma companies are doing a phase 4 clinical trial. Maccabi is definitely not a part of all a lot of those clinical trials. There is a very, very strong deviation between, and I will show it like in 2 minutes, between the numbers of phase 4 clinical trial, real world evidence clinical trials that are being held in Israel as we speak, and the amount of those clinical trials that an HMO eventually is participating in. And the reasoning for it is very wide. I think most of it is because pharma companies in general still do not, I'm trying to be very, very delicate or politically correct. They are still not sure that the community is ready, strong enough, or even, again, professional enough to carry on clinical trials. I think all of the pharma companies, we need to remember they are not Israel-based. They are not familiar with the Israeli health system. They are not familiar with who we are, with our reputation or our abilities. For them, there is the hospital and there is a GP that sits somewhere in a specific clinic. He does not see a medical record, nothing is being connected, and nothing is being done professionally, and most of the care is being given within the hospital. It's funny enough, when you go abroad, you see a place that for us, we can call it a Maccabi clinic or a Clalit clinic or a Leumit clinic or whatever. And in other countries, that same place is referred to be a hospital. So to convince the global market that HMOs are very strong here, and it was amazing. We did prove it during the COVID pandemic and the vaccination. We did an amazing job, but still in clinical trials, we are not there. And that is my day-to-day job, to convince pharma companies, not just the local branches of pharma companies, that we have abilities to do clinical trials within our settings. But it's also a lot of convincing that needs to be done within the world. And I guess at the end of the day, we need to prove that we are able to do it. And it's not easy. It's not easy because of multiple things. And we need to change the way that we look in clinical trials. Again, most of them are being done within hospitals. And I'm not sure that anyone even asks physicians, are you in the hospital? Are you willing to participate in a clinical trial? Are you willing to be a researcher in a clinical trial? It's something that they do as a part of their work, but somehow in Maccabi or in other HMO clinics, it's not that simple, because it's not a part of the DNA of the organization. It's not a part of the day-to-day work when you every 5 minutes you need to see your patient and to take another responsibility, because obviously participating in clinical trials adds a lot of responsibility to the physician itself. I don't have a lot of time. I'm running. Why is it important? What is the advantages of conducting those trials? For doctors, for example, you will receive further data on effectiveness in real-life practice settings, and you can make better decisions about therapies and respond to patients' expectations. For health authorities, they will be able to be more fully assess the benefits of the treatments, since they will have more real and not pre-selected patients. You will have the real experiment with those patients. Patients will receive additional indications of what result they can expect from a specific treatment, etc. I don't want to go into it. Just a bit numbers, because we have like 5 minutes, and I do want to talk about it. So I try to examine, I try to check, not this year, I mean, since 2023, we had in Israel as a whole, a lot less clinical trials and a lot less collaboration, research collaboration with the world. And again, we are talking about a lot of global collaboration, and we've seen a lot less clinical trials that are entering Israel, and at the same time, startup companies that are locally developed a product here in Israel are having a hard time to recruit money due to the war. So this is something that we are experiencing a lot. So if we are looking at the database of clinical trials to the year 2023, so we can see that almost 500 phase 4 clinical trials were conducted in Israel. Okay, more than 300 of those clinical trials were conducted in the hospitals. I mean, the numbers are very, very, very strong. even though by definition that real-world evidence is something that you practice in the community and not in the hospital, still the majority of those clinical trials and other phases as well, obviously, but we are talking about the real-world evidence, are being conducted still in the hospital. 42 are active, open for recruitment in Israel. The retention rate is pretty high, less withdraw. And up to 2020, only 20 studies were conducted in an HMO. I'm not talking about Maccabi, I'm talking in general. Up until the year 2020, only 20 studies were conducted in an HMO. And when I'm saying HMO, again, I'm talking about Clalit, Maccabi, Meuchedet, Leumit. I'm not sure that they are even doing clinical trials in general. But and when I'm saying Clalit, we are not talking about the hospitals of Clalit. We're talking just about the clinics themselves. And after 2020, obviously after COVID, we saw that we are starting to shift. A lot of clinical trials are shifting to the community as well. And that is something that we are very happy with. Just a broad number, just to give you a small sense. At the moment, we have 6 phase 4 clinical trials. Just phase 4, we have phase 2, and we also have phase 3 clinical trials in 16 sites, meaning clinics, meaning with different doctors that are acting as primary investigator or sub-PI, with thousands of patients that are being recruited on a daily basis. And when I sum it, the number of doctors that are actively, just on phase 4 clinical trials, that are actively recruiting today are over 30 researchers, again, throughout Israel. I can go on and on. I can definitely share the screen with you, but we are at 8 o'clock. So maybe I will open the session for a question or two if you have it.
Thank you.
I'm sorry, I told you it's like it's a whole course.
Zafer, first question for you.
Yeah, thank you so much. I did my best to be the first. That's why I raised the hand first.
Yeah.
First of all, thank you so much for the presentation. Actually, it was interesting, all what you said, especially when you talk about RWE and the phases that you are doing in HMOs. For me and for us in general as startups, big data is very important because it's a way of validating our market assumptions with a real evidence, and it lowers our risk in investment, and at the same time increases or maximize the growth opportunities. So for me, for instance, or anyone, if I want to go to you or come to you and try to use or get benefit from the big data that you have, because you said that you have 30 years of big data, so it means lots of data. What are the channels or let's say regulations that I have to come through to obtain such data? And also the whole time when you talk about the relationship and the, let's say, the trials, and as I understand or felt that there are always obstacles or hindrances that reduces the chances of HMOs to make, let's say, trials. And you mentioned at the beginning that one of the main reasons because DNA is only at the hospitals. That's why we can do all the kind of trials. Do you think there's another way to give you more space as HMOs to do these, let's say, trials in the future? Because I feel that there's space, but by the end, it's closed space, not open space for you. So what are the, let's say, potential efforts should be done to have this
Okay.
chance.
Mhm.
And third one, my name is Zafar Sabbah once again, and I wanted to ask you, how can I be in touch with you, because I have something in mind and I would like to consult you in it. Thank you so much.
Okay, I will start with the third.
Okay.
Very easy. Jafar can just forward my email, and I
I
think
already
I'll
shared
send my,
her LinkedIn also, Zafar.
yes, and my LinkedIn
Yeah.
also
I
has my.
sent you a connect request already on LinkedIn.
Okay, so yeah, I'm sorry, I was busy. I was just giving a lecture.
No, I
so-
just in the presentation, not before.
Yes, so that is the first. Second, I will divide my answer to your second question to two. My responsibility and your responsibility. My responsibility is to convince and to market the HMOs to the pharma companies. I will do the most amazing marketing work. But at the other end, I need the physicians with me. I need a physician, I need doctors
Exactly.
that would want to participate in the clinical trial, that will have that drive to be a part of the network, to recruit patients. I will give them everything. They will be paid. They will get a clinical, a study coordinator. They will get all the equipment. But I need them. I need you to agree or to want it and to see the importance of it. And as soon as you have one success with the pharma companies, the other ones follow. You prove yourself once, they are coming. Eventually, their motive is to finish fast, to recruit patients, to have Israel as a site, to be first in the world. So if we bring them the goods, if we do what we said that we will do, they will come again and again and again, and the rumor flies fast. But if I spend months on finding the right doctor and to convince him and to participate in the clinical trial and to be a part of it, that can kill a clinical trial. We need doctors with passion to do it. Again, they will be reimbursed. They will get the prestige, and they will go for all the events and for the investigator meeting in all over the world, etc. But they just need to want to be a part of it. And I'm telling you, it's something that is feasible. We are doing it. That was the second question. First one, I'm trying to remember what was the question. How can we collaborate on validation and big data? So big data is a different department. It's not my department that I'm run, but obviously I'm a part of KSM, so I'm well aware of the procedures. It's not that complicated. We have a department. You just need to write to one of our managers within that department and to establish a connection. But I started by saying that our research institute is self-sustained, which means all the activities that we are performing is sponsored. So if you want access, even if it's academic research, if you want access to data, and you want our data scientists to bring you that data, to upload it into a cloud, to do it in a very controlled way, it's something that needs to be sponsored. So you will have to find a budget for it. You can ask for grants. There are plenty of ways how to get funds for research.
Thank you so much.
Great.
Dr. Ismail, yeah. Dr. Ismail, mute.
You're mute.
Sorry. Thank you very much for a very interesting lecture. And I need to present myself. I'm the founder of the Neuromod Vision, a company developing a device for.
We lost you.
Again, Dr. Ismail.
Further in clinical trial trials. And I think that it might be a good chance to collaborate with you in order to run this clinical trial. Especially, our device is simple to apply, and I think that the facilities in your clinics, eye clinics in particular, could be enough in order to run this study. Indeed, we got marvelous results regarding this treatment, where the retinitis pigmentosa in untreatable condition anywhere in the world. So this is something that we might discuss and see what the opportunities in order to run multi-center study in your facilities.
We would love to.
Yeah, great. So we will go further, and we might have an appointment with you, and we might present what we are doing, and even our clinical trial protocol is ready in order to implement. So we might go further in order to use your facilities and your staff and your clinic in order to test this fascinating device for treating this untreatable condition.
Great. Looking forward.
Yeah. So we are looking again how to proceed. Then maybe Jafar will assist us to go ahead.
Small email at first. We'll start with a small email as usual.
That would be great. Yeah. Thank you very much indeed. Thank you.
Any questions? Who's raising hand? Dr. Ismail. Galit, thank you very much. Appreciate
Thank you.
It was
Nice
an amazing
meeting you.
session. Thank you very much. Appreciate it. Thank you.
Bye.
Thank you.
Bye bye.
Thank you.
Thank you.
Thank you very much.
يعطيك جماعة.
يوم طويل وسيشن طويل. يعطيكم ألف عافية.
الله يعافيك ويسعدك. تسلم.
ظافر دكتور إسماعيل، نراكم إن شاء الله.
إن شاء الله.
يسلموا للجميع. إحنا إن شاء الله الانكيبيشن يوم الاثنين هون، والليدرشيب إن شاء الله التخريج رح يكون يوم الثلاث إن شاء الله. عزية كيف حالك؟